So now we begin our academic session. Session 1 on pediatric gliomas, holding on to seeds of hope. And this session is supported by Johnson & Johnson Private Limited. May I now have the honor of inviting on the stage our respected chairpersons, Dr. Sunita Elawat. She is Principal Consultant Histopathology, SRL Fortis Memorial Research Institute, Gurugram. Dr. Ramandeep Arora, Consultant Pediatric Oncology, Max Super Speciality Hospital, New Delhi. And Dr. Rajiv Jha, Professor of Neurosurgery and Senior Consultant at BR Hospital, Nepal. Please welcome on the stage. I request the chairpersons to please invite the speakers for their respective talks. Thank you.
Good morning, everyone, and thank you to the organizers on behalf of all of us for inviting us and for this session. Just before I invite the speaker, I think it is very important to highlight that pediatric low-grade glioma is one of the 6 WHO index cancers identified for special focus. So it is very apt that this is where we start a session, and we have got a lineup of 3 great speakers. May I kindly invite Dr. Manmohan Singh to talk on the surgical and technical nuances in this area. Dr. Manmohan Singh is the Professor, Department of Neurosurgery and Gamma Knife Center at All India Institute of Medical Sciences. Thank you.
Good morning, everybody. I would like to thank Aditya and Gupta and the organizers for giving the invitation for delivering a talk on pediatric gliomas. Okay, so the common locations of the pediatric gliomas are infra, supra, and the midline gliomas, and the majority of these tumors are low grade. And out of these low grade, the pilocytic astrocytoma is the most common. If we see the current standard of care, the maximal removal of the tumor, the resection, is the standard of care. And because it relieves the mass effect, it improves the survival, it helps in controlling the seizure. If we see that if he improves the resection limits, the post-operative seizure control is better. And in the gross totally excised tumors, the seizure control is up to the tune of 90%. And it also improves the efficacy of adjuvant chemotherapy and the radiotherapy. And even in the age-adjusted and for the KPS, it improves the quality of life and independently associated with the overall survival, progression-free survival, as well as the malignant degeneration-free survival. So that we all have to know that we need to excise these tumors to the maximum, and it has to be safe. And for these, we need a special care for these tumors. And even for the very, very eloquent region gliomas like motor area, language areas, and even in the deeper structures, so the maximal excision is possible, and because the temporary deficit may be initially in a higher range, but the permanent deficits are not much. So it again indicates that we need to excise these tumors to the maximum. And how to help in achieving this goal? So for that, we have the maximum armamentarium in our kitty, like the image guidance, like in the intraoperative neuromonitoring, in the QSA, and a good quality cautery, then a good illumination and magnification in the form of current high-end microscopes, then the DTI, the intraoperative ultrasonography, then the intraoperative MRI, robotic guidance, awake craniotomies. These all help in improving our margin of safety as well as the extent of resection. If you look at that, the functional neuro navigation is helpful in identifying the speech areas preoperatively and the other important areas in the brain, so that we are exactly focused on the area of interest and help in preserving the function. Then the diffusion and diffusion tensor imaging also help in the identifying the main traps which are in and around the tumor, so that we are knowing preoperatively that where we are going to hit these traps, so that we can localize our resection limits, so that it improves the functional outcome postoperatively. And intraoperative neuromonitoring, it helps in significantly reducing the neurological deficits and improving the gross total resection. So it is very important to have the help of intraoperative neuromonitoring, which is important nowadays. Another kitty in our armamentarium is the fluorescence guided resection. Know that this is the new entrant. It also helps in maximizing the resection and improving the function. I think these 7 points are very important for all, I think, in entrant to the glioma resections. And it is important to focus on these 7 tips. So first important tip is the evaluation of preoperative imaging. And I personally feel that the T2 images and the contrast images are the most important in all planes, and also help to identify the neural as well as the vascular relations. Because many times these gliomas, they are very closely associated with the vascular structures, and many vessels, they actually cross through the tumor, or they are very in close proximity of that. So you have a 3D anatomy in your mind preoperatively, so that you are not going to injure them, and so that the postoperative complication is high. Many times what we feel is that a tumor which we resect, we feel that we have damaged the cortex or the subcortical structures, but it may not be the reason. Many times we actually damage the vessels, the end passage vessels, which leads to the ischemic deficit in the surrounding tissues. So that leads to a significant deficit postoperatively. So the preoperative image evaluation is the most important. We just can't go to see a glioma and go and operate. We need to have this thing in mind, that what are the relations of these vessels and the other neurological structures in relation to these tumors. A delayed knowledge of the 3D anatomy of the brain is important. So you always have in mind that because many of these our patients, they are in different positions, supine, lateral, in the prone position, in the sitting position, so that you have this 3D anatomy in your brain. So you know that once you are going through a corridor and you are attacking a tumor, so this is the limit, and this we are going to hit. And another the third point is that choosing a good surgical corridor and the surgical approach, so that it is anatomical, it is not going to have a good, not going to have a retraction, and also not going to damage these neural structures. Then we have to, fourth point is that to choose a good appropriate entry point. So many times these are the deeper structures, and we are going through the cortexes. And so that you need to choose a non-eloquent, and where there is nothing much is there, or even if there is a significant area, so that we are going to create a very minimal deficit in the post-operative patients. Then another fifth point is that identifying the plane of cleavage. All low-grade gliomas to me that they always have a good plane of cleavage. So you have to identify them, and you have to be in that place that the brain tumor interface always gives you a chance, so that you are minimizing the deficit. I'll show you the videos that. So even those tumors which initially look very, I would say that difficult, but the plane of cleavage can be developed in them. And I talked about that, the preserving the end passage vessels, and then the minimal and appropriate use of cautery. I've seen that people are doing a lot of cautery, and many people advocate that, because that you coagulate much, you make a bubble out of that, and then suck out and do that evacuation. But I tell you that many times this is counterproductive, because the thermal damage to the end passage vessel, even the small perforators, can lead to a lot of damage postoperatively. And my approach is that the minimal use of cautery during the surgery. So this is a motor step lesion. A young girl, and around 13 years. So this girl had one episode of seizure, followed by a little bit of post-operative deficits. This is the hemiparesis. And when she was imaged, so this is the motor area tumor. So this patient was initially imaged, and we did a craniotomy under general anesthesia, not awake. And we are intraoperative this monitoring is done. We are identifying various part of the right side, that upper hand area, upper limb, so that we know that where exactly is that. So that we chose the premotor sulcus. So open the premotor sulcus. So this is important. So opened up the sulcus completely, and going anterior to the gyrus. So once you have, this part is important. Just don't go and enter into the gyrus. So make an entry point, And now once we are sure that there is nothing there, and then we did a little bit of corticectomy just inside the sulcus. So inside the sulcus through the anterior part of the gyrus. So once we are inside the tumor, so initial debulking followed by, now you see that. So you can always develop a plane here. So in many of these tumors, so these tumors have developed a brain tube interface, which has to be identified, and a gentle blunt dissection is important, and you carry out, and you can peel it off with the help of your suction, a cottonoid, you can push in and around, and so that you can peel this tumor off the normal structures. And this is possible, and this is likely to create minimal or no deficit postoperatively. So this tumor was resected, and it is actually was peeled off and debulked with the help of CUSA. And very minimal use of cautery. So, and again, there was no loss of any neurological function intraoperatively and at the end of the section. And there was no postoperative deficit. The deficit which the girl had preoperatively, it remained like that and never worsened. And this is the postoperative scan of the patient, and there is complete resection, and the patient is doing well. The biopsy postoperatively turned out to be the ependymoma. Patient received radiation therapy, and she's doing well at 3 years down the line. And this is again a midbrain anteriorly located, I would say the anteriorly exophytic glioma. So this tumor is important to, I would say that approaching, how to approach. Everybody likely to approach in a different way, like transsylvian, sometime maybe a subtemporal, or excising the anterior part of the temporal lobe. But there are other ways to excise these tumors. So this tumor was excised with the pretemporal transpeterous approach. So for that, you need to have knowledge of the skull-based approaches. So this whole of the anterior temporal dura was stripped off the lateral wall of the cavernous sinus, and all the three divisions of fifth nerve was identified, and this temporal dura was peeled off from the cavernous sinus lateral wall. Clenodectomy was done. So now the dura is incised, and then the T incision is given till the anterior clinoid process, Sylvian fissure opened. Now, whole of the temporal lobe is retracted back, and it is actually I would say that 3 centimeter behind. Now, this is internal, the tumor is in the vision. This is posterior communicating artery, and which has actually very thinned out, and it was sacrificed without any consequences because it's not dominant, and preserving its perforator. And now the tumor is just in front of you, and it was nicely excised with the help of ultrasonic aspirator. This is a postoperative image. So again, this is another part of the midbrain tumor, but this tumor is actually a little on the lateral aspect, similar to the previous one, but you see that it is more on the lateral side. So initially we planned the same pretemporal transcavernous approach, but at the once we did that, we split that Sylvian fissure. We saw that lot of vessels are there. The PCA is in front of us. Then we saw that all the perforator, the PCOM was also not very good. We couldn't sacrifice it. So initially we planned, but again, then we abandoned it. Then we directed our attention toward the subtemporal transpeterous approach. We drilled out the petrous bone, divided the tentorium, and then we are on to the lateral part of the midbrain. These two vessels are actually on the PC and the superior cerebellar artery. With the help of these intraoperative neural monitoring, we identified that there is no stimulation of any kind, and we entered this brainstem from the lateral aspect. And this was, again, the tumor was dissected off with a very good plane of cleavage. You see that this is a all white brainstem structure inside is visible, and the whole of the tumor was excised. So this is the pontomedullary glioma, you see that. So initially it was diagnosed as the DIPG, seen somewhere else and sent to the AIMS for the radiation therapy. Then the radiation oncologists sent this patient to us. So initially we also thought that this is involving the whole of the medulla and may not be possible, but we did our DTI and everything and then realized that probably it is not a DIPG and it is a focal glioma, which is expanding the brainstem very significantly. And we went ahead with the surgery. You see that. So in the midline posterior fossa approach, and you see that this is a brainstem. This is the cervical cord. Yeah, just a minute. So same thing, entering on the brainstem on the lateral aspect and tumor debulking. Now see that this tumor is having a very good plane of cleavage. Initial debulking with the help of CUSA, and then this is the development of the plane. So this tumor was again actually shelled out of the brainstem. And this is my very constant observation that many times we enter into the brainstem, into the tumor, we suck it out with the help of CUSA, and we stop thinking that there is no plane of cleavage. You need to develop it and you need to identify it, and many times it is possible. So this is a complete excision, and this turned out to be the pilocytic astrocytoma. So these are the post-operative images. Now you see that this whole of the brainstem has actually bounced back to its normal self and looks like as if not operated. And this is the patient in the post-operative image with the no deficit post-operatively, and she is doing very well. Thank you, sir.
Thank you. That was excellent, and thank you for being on time. We have just finished time. I think we can just take one question if someone has a question, and otherwise we'll move to the next speaker. Can somebody pass a mic to?
Have demonstrated beautiful, but what is the complication percentage? You have shown always good cases, but there must be some cases.
Exactly. So these patients, many times they present, majority of them present with the cranial palsies, especially the lower cranial palsies. So that is a usual presentation with the many patients, they have quadriparesis also. But thing is that these deficits, if we are operated well, so they should not deteriorate further. The most important thing is that they require post-operative ventilation for quite some time. Usually around 2 to 3 days is the standard, but many times these patients may require a little longer post-operative ventilation also. But once it is done, the patient gradually recover, and few of the patients may require tracheostomy also. But I can tell you that most of these patients, they do well. Yeah.
Next speaker, Dr. Suvendu Purkait, is going to enlighten us on the most difficult area of the, excuse me. He is associate professor in the Department of Pathology, AIMS, Bhubaneswar. So he's going to talk on the most difficult aspect of pathology, that is the molecular markers, and how they are going to change our approach and diagnosis on pediatric gliomas. So, Dr. Suvendu.
Thank you, ma'am. A very good morning to all. At the outset, I want to thank the organizer for giving me this opportunity. The title of my presentation is Expanding the Impact of Molecular Markers as per WHO CNS 5 classification on pediatric low-grade glioma, diagnostic wizardry. So what a wizard supposed to do? A wizard do amazing thing by transforming various living or non-living things into other. So they have a magic wand. So what magic wand the pathologists have? If we have a precision histopathological diagnosis and a high-end molecular setup, we can convert the undiagnosed or non-otherwise specified neoplasm into a distinct tumor entity. That is the main concern of WHO classification this way. Throughout the human civilization, change is the only thing which is constant, same as in WHO CNS classification. In WHO 2016, the pediatric type of glioma, they are considered as a provisional nomenclature, and they are named as pediatric type diffuse astrocytoma or pediatric type oligodendroglioma because of lack of adequate data on them. But in 2021, for the first time, they are enlisted as an independent group because this tumor, they are distinctly different from their adult counterpart. They have distinct molecular profile which is separate from the adult. They had a favorable prognosis as compared to their adult counterpart. And importantly, they usually does not progress as like the adult low-grade diffuse gliomas. This pediatric low-grade glioma, they constitute approximately 1/3 of the total CNS neoplasm. And if you go by the classification, the pediatric low-grade glioma, they are usually CNS WHO grade 1 and grade 2 tumor, and they are pediatric type low-grade diffuse glioma and circumscribed glioma. The circumscribed glioma, although they are not specific for the pediatric age group, but many of these entities, they are commonly occur in pediatric age group. Thus, WHO has enlisted 4 entities which comes under this pediatric type diffuse low-grade gliomas, which is diffuse astrocytoma, MIV or MIV-L1 altered, angiocentric glioma, polymorphous low-grade neuroepithelial tumor of Young or Flanty, and the diffuse low-grade glioma MAPK pathway altered. Out of this, these first 3, they are graded as WHO grade 1. However, the diffuse low-grade glioma MAPK pathway altered constitute a heterogeneous entity, and WHO still to assign a grade to it. On the other hand, circumscribed glioma, as we all know, the major is the pilocytic astrocytoma, which is the commonest CNS tumor in pediatric age group as well. The other tumor, which is subependymal giant cell astrocytoma, pleomorphic xanthoastrocytoma, chordate glioma, and astroblastoma MN1 altered, these are may be seen in pediatric age group, but they have a wide age distribution. They are more common in adolescent and young adult. And we should never forget that adult type of diffuse glioma, they also may occur in pediatric age group, although they are quite rare. So coming to the pediatric low-grade diffuse gliomas, these are distinct histomolecular entities. That does mean the diagnosis require incorporation of the histological as well as molecular features, which in the form of layered diagnosis system as proposed by ISN Harlem classification in 2014, which is later on adopted by the WHO 2016 and by WHO 2021 classification, which has 3 distinct layers along with integrated diagnosis, which constitute the morphological diagnosis, the WHO grading, and the molecular profile of the tumor. So coming to the molecular profile, this pediatric low-grade diffuse glioma has 3 main major genetic alterations, which are MIV-L1 structural variation, the BRAF alteration, the FGFR alterations. Other minor genetic alterations are also described, but their frequency are quite low. So coming to these common features, these molecular alterations are aligned with specific clinical setting and pathological features of the tumor. And these are the potential genetic driver mutation in majority of the cases. Fortunately, these mutations are mutually exclusive, and they represent distinct methylome clusters. The MIV and MIV-L1 structural variation include the structural rearrangement of these genes and one MIV-QKI fusion. These are the predominant alterations, and these alterations genetically associated with high expression of this gene, which is ultimately related to cell proliferation and differentiation. This tumor usually occurs in a younger adult with a median age of 5 years. They are hemispheric tumor, and these MIV-L1 alterations are commonly associated with diffuse astrocytic morphology, while the MIV-QKI fusion, they are quite characteristic of angiocentric glioma. So this diagnostic technique, this can be diagnosed by fluorescence in situ hybridization or quite easily, and you can use 3-color probe using 5' 3' end of the gene and a centromeric probe for the control. So this particular picture shows a chromosome copy number gain of MYB L1. Coming to BRAF alterations, the BRAF V600D mutation and the KIAA1549 BRAF fusion is the commonest alteration which are described, and BRAF V600D is a missense mutation where the valine is replaced by the glutamic acid and it is associated with constitutively activation of the BRAF gene. On the other hand, the KIA BRAF fusion is also associated with downstream activation of the DAS-MAP kinase pathway. The BRAF V600E mutation is commonly seen in the plenty group, the astrocytic morphology. They are quite rare with the oligodendroglial morphology. On the other hand, the KIA BRAF fusion, they are quite rare in diffuse type of pediatric glioma. However, they are the principal mutation in cases of pilocytic astrocytoma. Diagnostic techniques for BRAF V600E, the specific clone, that VE1 clone, can be diagnosed by immunohistochemistry with a very high sensitivity and specificity, and the Sanger sequencing, one of the commonly used methods to detect this point mutation. The BRAF KIA fusion can be detected by FISH using decapod FISH against the BRAF gene. The FGFR alteration FGFR is a receptor tyrosine kinase which is expressed on the cell membrane, and this also plays a crucial role in the cellular development. The alterations include FGFR mutation, FGFR fusion, and tyrosine kinase domain duplication. This is also associated with downstream activation of the same pathway, that is RAS-MAP kinase pathway. These mutations are commonly seen in oligodendroglial morphology, and they are quite rare in astrocytic morphology. The diagnostic technique, this mutation can be detected by Sanger sequencing, the fusion can be detected by FISH, and most of the study they have used NGS-based platform for diagnosing this duplication. This is another important druggable target, and several FGFR inhibitor has been available in clinical trials. The other mutations which are quite rare, as I told, but they are also associated with this MAPK pathway alteration. Among these, FGFR 2 and 3 fusion are detected in around half of the cases of plenty. Coming to the histological features, this, as I told, the histology and molecular features, they coincides. This generally, this whole group of tumor has a diffusely infiltrating nature. That's why they are called as diffuse glioma. They have lack of morphological atypia. Mitotic activity is usually not seen. Even if it is seen, it is quite rare. Endothelial proliferation and necrosis should not be seen. If anybody is in this picture, this should be assessed for the other higher grade glioma, and this should be assessed accordingly. This tumor shows glial differentiation in the form of GFAP and olig expression. Neuronal markers are negative, like NUN, synaptophysin, they are all negative. MIMO leveling index is very low in this tumor. So this specific entity, like angiocentric glioma and plenty, they have a specific histopathological features. While the other two entities, like diffuse astrocytoma, MIB altered tumor, and MMPK pathway altered tumor, they does not have any specific histological features, and they can present either astrocytic, oligodendroglial, or mixed histological features. This angiocentric glioma, this is a pediatric tumor of the pediatric and young adult. This tumor is associated with intractable epilepsy and also enlisted under the long-term epilepsy associated tumor. Hemispheric location is common with temporal and frontal lobes. The histology is characteristic, as I told. There is perivascular orientation of the tumor cells which mimic sometime ependymal pseudorosette, and these are comprises of the bipolar cells with granular chromatin, which sometimes mimic an ependymal features. They have characteristic perinuclear dot-like immunopositivity for EMA, and characteristically these tumors show MIB QKI fusion in up to 100% of cases in different studies. Again, plenty, this is a newly described entity as per WHO 2021. This has a similar chemical profile as like angiocentric glioma. However, this tumor has a compact growth pattern with diffuse margin. They have a oligodendroglial cells, and astrocytic cells may be seen, although they are rare. Calcification is one of the common features of plenty. they show strong positivities of CD34, although it may be diffuse or some cases may be focal. This tumor either show V600E mutation, which is present approximately 40% cases, while FGFR2 or 3 fusion can be present in half of this tumor. The other diffuse glioma, as I told, the MOIB altered tumor and MAPK pathway tumor, they does not have any specific histological features. Their diagnosis hence depend upon the association of their molecular alterations. But we have to remember the diffuse astrocytic tumor, this MOIB altered tumor and BRAF mutated tumor, they commonly have a astrocytic morphology, while the FGFR mutated tumor, they commonly shows the oligodendroglial morphology, but it is not 100% certain. So coming to the correlation of histology with molecular parameter, if histologically the tumor is diffuse astrocytoma-like, so though more common genetic alteration is likely to be V600E alteration or MOIB alteration. If the tumor is oligodendroglioma-like, as I told, the most common alterations are related to the FGFR gene. They can be duplication, copy number variation, or fusion. On the other hand, in angiocentric glioma, MOIB QKI fusion is the characteristic, and in plenty, we have FGFR fusion and BRAF mutation are characteristic. However, there is morphological and molecular overlap. So this tumor, this first three group of tumor, which is already assigned by WHO as a grade 1 tumor, although there is limited data, but this tumor behave in an indolent fashion and they are amenable to control by surgical resection. On the other hand, diffuse low-grade glioma MAPK pathway altered have a uncertain as a tumor group. They have heterogeneous, their outcome depend on the location, morphology, and molecular profile. B600E mutated tumor usually seem to have a higher rate of progression, same as tumor with CDKN2A2 deletion. Let's be coming, just I'll touch the circumscribed glioma a little bit. So circumscribed glioma, the major is the pilocytic astrocytoma, which is the most common low-grade glioma in children, around 18% patient. They have characteristic histological features which can be, by which we can be diagnosed with compact and loosely textured area and has rosenthal fiber or eosinophilic granular bodies. Pertaining to molecular alteration, as I told, the Kia BRAF fusion is the most common, which can be detected by FISH. Other alteration like NF1, FGFR, mutation and fusion can be seen. Just I will touch the molecular alteration characteristic of the other circumscribed glioma like pleomorphic xanthoastrocytoma, commonly associated with BRAF mutation as well as CDKN2A homozygous deletion. Astroblastoma is this structural rearrangement of MN1 is essential for diagnostic. The chordate glioma usually have PRKCA gene mutation, and SEGA has mutation in the TSC1 and 2 gene. So commonly used molecular platform or immunohistochemistry, which can effectively diagnose the BRAF mutation and other genetic alteration like IDH and ATRX in adult glioma. In FISH, MOIB related alteration can be effectively depicted, same as all the fusion depending upon the availability of fold. Sanger sequencing is usually used to detect the point mutations. However, other high throughput technique like nanosting encounter, NGS platform, methylome profiling can be used, but these are not that much cost effective. However, WHO has not recommended any specific platform or method. So to conclude, low-grade gliomas are the most common primary CNS neoplasm in the pediatric age group. The majority of the tumors are circumscribed. Pediatric type of diffuse glioma regarded as a distinct histomolecular entity as per WHO 2021. They are histologically low-grade and molecular alteration most related to the MAPK pathway activation. They are related to MOIB alteration, BRAF alteration, or FGFR alteration are common. There is significant degree of molecular and morphological overlap. They usually have indolent biological behavior in most of the cases. Molecular alteration are important for therapeutic implication as well. Thank you.
Thank you, Doctor. Thank you, Dr. Suvendu. We can have one question.
So, where would you put the diffuse leptomeningeal glioneuronal tumor in this?
Diffuse leptomeningeal granular tumor is a glioneuronal tumor. that is in a separate group. In gliomedular tumor, we have different entity. That's one of the entities, diffuse leptomeningeal gliomedular tumor.
I was going to ask the same. DLGNT also you have to put somewhere.
No.
You showed the oligo-like features, so you could put.
Yes, sir. Sir, diffuse gliomedular tumor and other like ganglioglioma, those belongs to the gliomedular tumor group.
Oh,
So I am talking about the glioma group only. The gliomedular group are made separate, and the glial group, they are made separate. In glial, we have circumscribed and diffuse glioma. What I
Very two brief points. I think you made a wonderful presentation. It was very nice. IDH you must emphasize somehow, which is so ingrained in our mind. Tell the audience IDH is usually negative or rarely positive. That also is an important point. And lastly, although some of them plenty, even angiocentric gliomas and others, they tend to be low grade, grade 1, but occasionally we have seen being aggressive, and that molecular profile also is relevant in clinical practice.
We are still getting to know these tumors. Yeah, it takes about 10 years to know tumors, especially so rare. And angiocentric is new baby.
And then the WHO changed its classification.
Yeah.
Thank you. Now, I would like to invite Dr. Srinivas Chilukuri, who is a senior consultant radiation oncologist, Apollo Colon Cancer Center. And the topic is talking on when and how to radiate a child with low-grade glioma. Is early too early and late too late? Dr. Srinivas, please.
Good morning, everyone, and would like to thank the organizers for giving this opportunity, and especially this interesting topic. The title of the talk is early too early, late too late. Thank you, Dr. Indu, for especially for this title. So a few days back, a few weeks back, this was seen in outpatient clinic in our hospital by Dr. Jalali and his team. 2-year, 10-month-old child initially presented with diencephalic syndrome. VP shunting and a biopsy was done, was confirmed to be a pilocytic astrocytoma. You can see a large opticochiasmatic glioma. Started on vincristine carboplatin till 2017 as expected, which is the first line of therapy. And you can see that there seems to be some partial response as far as imaging is concerned. Everything was going well, but presented with progressive visual loss, and then started on weekly vinblastine. You can see at the time of 2017, but also during the chemotherapy had developed febrile neutropenia a few times, developed Acinetobacter meningitis, for which the child had to be on a ventilator support. So progressed on all vinblastine chemotherapy after 4 years in 2019. Visual loss was little more profound. There was mild weakness, hemiparesis. There was precocious puberty, was started on leupride injections. Recurrent hyponatremia was there in the child, and there were related hyponatremia-related seizures were happening. So in 2019, when the tumor really progressed, she underwent a tumor debulking, and it was confirmed that there was BRAF fusion, started on targeted therapy, trametinib in 2020. And this was the scan pre-trametinib. You can see on the left-hand side, fairly large, necrotic. Obviously, during the therapy, the child seemed to be doing well. There was some mild rash and some side effects, but otherwise continued to be on endocrine replacement therapies. But after a gap, went on a drug holiday, and you can see that after drug holiday, it progressed. And one wonders, from the time 2-year, 10-month-old child, 7 years, about 9-year, 10-month now, when initially the vision deficits were unquantified, but supposedly they were minimal, and now right-sided almost complete visual loss, left-sided field deficits, endocrinopathies, some amount of finite toxicities. So the question which we wonder was that we asked ourselves was, could we have offered radiation before loss of considerable visual function? Another case, published in Journal of Clinical Oncology 2019, 4-year-old boy for 7 years received all chemotherapies, first line, second line, third line, targeted therapies, bevacizumab, trametinib, everolimus, everything. Progressive right-sided vision loss, left-sided temporal visual field loss, cerebrovascular accident due to the tumor, hemorrhagic hydrocephalus, shunts, and so on and so forth, then referred to radiation. Before start of radiation, patient coned and died, unfortunately, at home comfortably. Again, the same question, could we have offered radiation to prevent loss of life? So these are two questions which haunt us when the patients come to us, radiation oncologists, and we know that for a fact, and there are multiple studies which have shown 10-year progression-free survival of 70-75%, 5-year progression-free survival of 80 to 90%, and overall survival, again, same 80 to 90%. And once they are progression-free, they remain progression-free forever. But for the risk, of course, there is, which is very well known, vasculopathy, second cancers, neurocognitive decline, endocrinopathy, secondary transformation, which are all known side effects of radiation. But has the pendulum swung too far that we are, so nihilistic about radiation? That broad avoidance of radiation because of fear of toxicities are putting patients at risk of high risk of morbidity and even mortality from tumor progression, even when RT may be an excellent, tolerable salvage option. And of course, the question of radiation and chemotherapy comes in the picture when depends on the location. If it's a diencephalic and brainstem, the middle portion of the brain, usually is diagnosed on imaging or maybe even just a biopsy. GTR or STR is almost rarely possible. They are more often symptomatic. Observation is very difficult. Chemo is considered standard of care appropriately. There is no controversy about it, no question about it. And radiation is definitely more challenging in this location. But in hemispheric location or non-diencephalic location, surgery is usually possible. Observation is a great option in majority of the patients, if not majority, most of the patients. Chemo is not that well established in these patients, and radiation is relatively safer. But if you see the large population-based studies, and this is why the perception in nihilism has come. This is published by our own friend Rahul Krishnatri from Canada, which is very well done study, I must say. But this is a large cohort study, retrospective study. We know the limitations of large retrospective CR database kind of analysis. But it showed that upfront radiation was associated with higher number of deaths, all deaths, and higher number of tumor-related deaths. But if you dig deeper, you see that in less than 5 years from diagnosis, patients were dying of tumor progression and tumor transformation, which is very, very unlikely after radiation. This is because most often radiation was being used to treat lesions in the brainstem and in thalamus, where we know that it could be histone mutant, which may not be really pilocytic. Majority of the patients being diagnosed on biopsy or even imaging. And more than 5 years, you can see that they were dying of unrelated reasons, accident, pneumonia, cystic fibrosis, etc. So there is a selection bias at different levels in these studies. Upfront radiation is used for more aggressive low-grade gliomas, highlighted by early deaths. Biopsy bias is there as well, only for deep-seated tumors. And radiation is offered for patients who progress multiple lines of therapy, which also indicates that probably we are irradiating the worst cohort of patients and first cohort of tumor biologies. If you see the prospective studies of radiation, which probably some bias is limited in these patients. This is a ACNS 0221 published a few years back, 85 patients, and NF1 was excluded, rightfully so, and MRI-based planning was used in all patients, and 5 millimeter CTV margin was used. Normally we use more than 5 millimeters, but they used 5 millimeter, and they showed that most of the relapses were actually central. But if you see that most of them received 42, in fact, in less than 10-year-old children, almost all of them received one course of chemotherapy before radiation. And you see that the PFS and OS was excellent. And this is what, not just this series, but other series as well, which compared similar kind of prospective outcomes in radiation have shown a similar outcome. But PFS and OS is very good. But what happens to late effect, that is very important. And this study is actually showing the power of prospective studies. 78 patients, mean age of 9.7 months, majority being diencephalic or midline location, no biopsy in 13, pilocytic astrocytoma in 67%. They followed a patient for 5 years, and at the end of 5 years, in fact, there were significant improvements in child behavior checklist. There were higher decline in NF1 patients. They included few NF1 patients as well. So except for spelling scores, almost all scores were acceptable in these children. Spelling scores were less in these children at the age of 5 years after the treatment, that is at 60 months. And what they did beautifully was they created a model of how IQ decline would take place. And they answer the question, what was the rate of IQ decline? This is very important to inform parents. So when other factors are excluded, of course, this is oversimplification probably, but a 10-point decline in IQ 5 years after RT would be expected for a child age 5 years at the time of irradiation by about 10. So 10-point decline in IQ would be seen in a 5-year-old child. Is it much? I don't know. Does surgery influence neurocognitive outcomes after radiation? Yes, surgery does influence. Impact of hydrocephalus or shunt is also very well known after radiation. This study also showed that not just high dose region, but even low dose region, which is V0 to 30 gray, influence the IQ decline. And this is irrespective of age. The volume of irradiation was important predictor of neurocognitive decline according to this particular study. They also shown that there was some endocrinopathies associated with radiation, no doubt. But what was more surprising, that at baseline, so many children had endocrinopathies. 12% needed thyroid replacement, 6% glucocorticoid, 4% desmopressin. Provocative GH testing showed 43% had moderate GH deficiency and 24% had severe GH deficiency. So these are very, very important things to consider before we go in. This is also another study, which is again exclusive proton therapy study, which is larger cohort, 174 patients. Again, showed excellent outcomes, although include a large chunk of diffuse astrocytomas as well. Local control was inferior in patients who had brainstem and spinal cord tumors, expectedly, as well as dose when it was restricted to less than 54 gray, probably because of inclusion of the diffuse astrocytomas as well. And there were very limited serious late toxicities attributable to radiation. And of course, there were few endocrinopathies as well, but it showed that it actually is very well tolerated in these particular patients. Coming back to chemotherapy, in diencephalic, you can see, I don't know, in non-diencephalic involvement. All these are prospective studies of chemotherapy, and they've shown that very few, 20%, 0%, 0%, only few patients of non-diencephalic tumors were included in these. So just to highlight the fact that in chemotherapy studies, most of them were diencephalic patients. What happens to ocular outcomes, when patients go on chemotherapy? Just to give you a reference, I just checked a few days back, what was the eligibility for driving license for, your vision. If it has to be more than 20/40 vision, which is 6/12, more than 6/12 in Indian. Snellen's chart is 20/40, Indian is 6/12. But less than 20/60, you cannot drive. Legally, you cannot drive. And you can see that this was one of the prospective studies which shown that ocular outcomes in children who receive chemotherapy upfront is actually pretty bad, unfortunately. You can see that a good majority, about 40, 45, 50% of patients had moderate to severe visual loss. Again, this highlights that visual impairment may not correlate with imaging. Sometimes imaging may show that there's this stable disease, but vision deterioration continues to happen. 40% of patients in better eye had vision ineligible to acquire a driver's license, and 1/3 of patients had moderate, and 20% had severe impairment in the better eye. Similarly, there are multiple other retrospective studies which shown that visual outcomes after chemo are not that good. Of course, there are some therapies such as bevacizumab which have shown that there could be improvement in vision as well. That is something which is there. But otherwise, most of the chemo, very little, less than 15% improvement in vision. Majority of them, stabilization of vision is what we usually see. Visual outcomes after radiation also are very, very similar on that aspect, stabilization of the vision. But how to monitor vision is also very important. Visual acuity and visual fields are standard, which is gold standard, but it's very difficult to be done. Visual evoked potential should also generally also considered in young children, but the problem is because chiasm is involved, you cannot compare between each eye. So VEP may not be very, very sensitive, and very subtle changes can bring a lot of alter the sensitivity of the test. So the standard which has been recommended is optical coherence tomography, which is OCT, which measures essentially retinal nerve fiber layer thickness, and that has been shown to correlate very well with visual acuity and visual fields. Targeted therapies, we all know about it from the seminal publication from the Heidelberg group of BRAF fusion to the recent randomized trial in BRAF mutated patients, where patients were randomized to chemotherapy versus targeted therapy, and you can see BRAF fusion and mutation are almost 50-50 as far as in diencephalic and brainstem are concerned. And the randomized trial has shown that targeted therapy is better, but you can see 1 year progression-free survival is 67%. That means 2/3 or 1/3 actually progress during targeted therapy as well. Bevacizumab also shown that although radiological response is 80%, the clinical response is only 57%. Serious, progression after stoppage of bevacizumab is also pretty high. So these are some of the concerns with targeted therapy as well. We do not know yet how long the duration needs to be given. So summarize, just to tell you, 10% of patients succumb, 10 to 15% of patients succumb to disease within first 5 years. Progression of primary disease is the main cause of death in the first 5 years at least. Presence or progression of tumors is associated with morbidity, significant morbidity. Visual morbidity could be others as well. OPG, significant vision impairment, most often have significant endocrinopathies. Chemotherapy is the standard of care when adverse effects are minimal and meaningful delay to radiation can be achieved. Chemo is associated with significant some toxicity or morbidity. Choosing chemotherapy instead of radiation as primary therapy risks neurological deterioration in patients who are difficult to monitor in the setting of stable imaging and may delay treatment of pre-existing growth hormone deficiencies. Targeted therapy appear promising, but we need to see long-term toxicities, visual outcomes, duration. Progression immediately after stopping therapy is also a concern. Any risk of loss of significant function or life, radiation must be considered on priority. Conformal radiation and proton therapy can minimize the risk of neurocognitive decline, learning disabilities, endocrinopathies, and second cancers. So when, the question I was asked is when and how. When is, there has been some attempt to stratify patients. If it is diffuse astrocytoma or if it is in thalamic and midbrain location, these are high risk. They have to be considered for radiation. If they are low risk, definitely one course of chemotherapy should be given. And when it is low risk, the role of radiation is controversial. Loss of moderate visual function, at least after one line of systemic therapy, RT must be considered and discussed with parents. How? Not very controversial. Conformal techniques with a margin of 0.5 centimeter, restricting doses to normal brain irradiation should be done. And there is good prospective data for proton therapy in this group of patients and can be considered wherever feasible. Long-term survivorship, of course, remain a major concern. Thank you.
Thank you, Dr. Srinivas. Nice presentation. I think we can take one question.
We don't know the answer, but it looks like it is better because of the age group of these patients, and especially in diencephalic location when we are irradiating. As I shown you that the low dose region, apart from the high dose region, is very, very important to reduce all the complications which I have mentioned. So proton therapy seems to be definitely very promising in these patients. I mean, we would choose upfront radiation more than 10 years. That is what is the standard usually. But we have to, as I mentioned, that loss of function or in a particular situation when we are facing a progression despite few lines of chemotherapy, then radiation should be considered irrespective of age.
So IMPT, the proton IMPT, the intensity model.
To begin with, I'd like to thank Dr. Indu and the organization.
Too much difference between IMRT and IMPT. But when you have to spare hippocampus, for example, and the low and intermediate dose is an issue. So that is one. The risk of second cancers has not been described so much, but that's an important issue too. And that is a direct correlation in the volume of low and intermediate dose wash, which is hugely significantly superior dosimetrically with proton as compared to photon, because photon would completely bathe the low grade volume, and that could have an implication for second cancers and vasculopathy. The age is also actually coming down. We used to take 6 years, then became 10 years. But with the advent of ependymoma data, where we are now delivering RT in 1 year, and especially the vision and other areas, as Dr. Srinivas already mentioned, the threshold is coming lower down with the modern proton therapy as well. So these are some of the things which will be defined prospectively in the next few years.
Srinivas, can I ask one
Yeah,
question?
sure.
Excellent presentation.
Thank you.
As usual, you have illustrated nicely. Just maybe, what is your take about the future of radiation for pediatric low-grade glial tumor, especially after listening to Suvendu's talk, that almost all pediatric low-grade tumors are universally MAP kinase driven or activated when you have an available targets of MEK inhibitor. So in this kind of scenario, what is your take on the radiation role?
Yeah. So, I mean, before coming to radiation role, I think I have to talk about a little bit about targeted therapy since you mentioned targets. Target therapy are no magic, wand in this pediatric low-grade gliomas, although they are driven. The question is it a single pathway disease or there are many escape pathways? If it is single pathway, it seems to be very promising, but at least initial data shown that some patients really benefit out of it. When you stop, the disease comes back. So we still are learning about the targeted therapy, how effective they are, what is the duration of treatment, what are the long-term toxicities of these on the neuro development. So we are still learning from it. So nothing changes as of now. The radiation will remain an option in certain patients of pediatric low-grade gliomas. With targeted therapy, eventually the chemotherapy use would come down, I assume. But radiation, again, as I said, in patients who do not respond, who are progress after targeted therapy or chemotherapy will remain always an option, I feel.
Thank you.
Thank you.
Thank you, respected chairpersons and speakers, for a wonderful kickstart to the session. Now, moving on to the next topic of discussion, pediatric diffuse high-grade glioma. May I now invite upon the stage our respected chairpersons, Dr. V.S. Mehta. He is Chairman and HOD Department of Neurosurgery at Paras Hospital, Gurugram. Dr. Amita Mahajan. She is Senior Consultant Pediatric Hematology Oncology at Indraprasth Apollo Hospital, New Delhi. And Dr. Gagan Saini, Director Radiation Oncology at Max Hospital, New Delhi. Please welcome on the stage. I request the chairpersons to please invite the speakers. And one announcement for the speakers that all of you will have to be the panelists for the upcoming panel sessions. So please be with us. Also, another announcement that there are standing mics for the audience, so you can please use them. Yes,
thank you so much. At the outset, I'd like to really compliment the organizers for putting together this amazing program. I mean, it really promises to be a feast. Pediatric-type diffuse high-grade gliomas constitute only 10% of pediatric CNS tumors, but are responsible for 40% of deaths. So it has, they continue to be extremely challenging for us, and defining, how best to manage them has remained elusive. But any further progress will truly come from understanding better the biology of this disease, and that will come from changing molecular, understanding the molecular diagnostics. So to talk on this, we have Dr. Vani Santosh. Dr. Vani Santosh is Professor of Neuropathology and Head of Transfusion Medicine and Hematology at NIMHANS, Bengaluru. And she's going to talk about the changing molecular landscape of pediatric-type diffuse high-grade gliomas, time to change the dated script. Dr. Vani is not here, so we have a pre-recorded presentation that will now be played on screen.
To begin with, I'd like to thank Dr. Indu and the organizing team of ISNOCON 2022 for inviting me to take part in this conference. Certainly a great pleasure for me. I wish I was there physically to attend this conference. Nevertheless, thank you for allowing me to give a pre-recorded talk. And I'll begin this symposium on pediatric-type diffuse high-grade gliomas by discussing their changing molecular landscape. As we know, the WHO 2021 classification, popularly referred to as WHO CNS, has been built up on the prior WHO 2016 classification and all the recommendations that have been put forth by the 7C impact now updates. And therefore, this classification advances the role of molecular diagnostics in CNS tumor classification. Nevertheless, it is deeply rooted to the established approaches of tumor characterization, such as histology and immunohistochemistry, and therefore it presents a hybrid taxonomy. If you look at some of the major changes in WHO CNS 5, it includes changes such as revisions in CNS tumor nomenclature, grading, restructuring of the tumor groups, introduction of new tumor types, subtypes that will be discussed by the other speakers. With respect to the pediatric CNS tumors, there's been a rapid transition from a morphological to molecularly driven classification, systematically taking into account the recent discoveries that have happened in pediatric tumor genomics. Now, if you see the major changes in diffuse gliomas in WHO CNS 5, it includes the division of diffuse gliomas into adult type and pediatric type, which was not there in the previous classifications, but has been introduced in this classification because now we know that these two groups of tumors are molecularly distinctly different, and there is division of pediatric diffuse gliomas into pediatric type high and low grade gliomas. I'm going to be discussing pediatric type diffuse high-grade gliomas. These are uncommon de novo tumors. They do not progress from lower grade gliomas like we see in the adults, and they're also molecularly different from the high-grade gliomas in older adults. And they're no longer referred to as glioblastoma in the pediatric type. All of them are referred to as the high-grade gliomas. And interestingly, there's a site-specific differences in their molecular alterations. For example, the molecular alterations of tumors located in cerebral hemispheres will be distinctly different from those located in the brainstem. Overall, if you look at their molecular pathology, the key discovery that best illustrates the unique biology of most of these tumors is the histone, somatic histone mutations involving 3 histone coding genes, that is the H3F3A, Hist1, H3B, and H3C genes that encode for the histone H3 variants, that is 3.3 and 3.1. Leading to amino acid substitution at 2 key residues in the histone tail, that is K27 and G34. And we know that these are biologically distinct tumors. So basically, histone H3 involves 2 variants, that is 3.3 and 3.1 that get mutated. 3.3 gives rise to H3G34R and V mutation and K27M mutation, whereas 3.1 gives rise to K27M mutations. G34R and V mutated tumors account for about 7% of this pediatric type diffuse high-grade gliomas. They're seen mainly in the cerebral hemispheres and in the adolescent. The 3.3 K27M mutated tumors occur in the midline structures such as the thalamus and the pons in the younger children. And the 3.1 K27M mutated tumors occur exclusively in the pons in very young children, and they have been earlier designated as the diffuse intrinsic pontine gliomas, or the DIPGs. And the wild type tumors account for more than 50% in this particular group. And if you look at these survival curves, you can see that the 3.3 K27M mutated tumors are associated with the worst prognosis, followed by the 3.1 K27M mutated tumors, then the G34 mutated tumors, and the wild type tumors are associated with the best prognosis in this group of tumors. So this is the classification of pediatric type diffuse high-grade gliomas in WHO CNS 5. They come under the major header gliomas, glioneuronal and neuronal tumors, and include 4 major tumor types: the diffuse midline glioma H3K27 altered, diffuse hemispheric glioma H3G34 mutant, diffuse pediatric type high-grade glioma H3 IDH wild type, and the infant type hemispheric glioma. And we should remember that the pediatric diffuse gliomas occur not only in the pediatric age group, but also in the adults and vice versa. And that is the reason they've been designated as pediatric type and adult type diffuse gliomas. So basically, pediatric type diffuse high-grade gliomas can involve the midline or the hemispheric regions. Midline tumors are now designated as H3K27 altered, which is a revised nomenclature from H3K27M mutant, because now we know that there are other alterations that can bring about this H3K27 alteration. And this includes 3 distinct tumor types: diffuse midline glioma H3K27M mutant, diffuse midline glioma H3 wild type with EZHIP overexpression, and diffuse midline glioma EGFR mutant. Hemispheric gliomas include diffuse hemispheric glioma H3G34 mutant, which occurs in adolescent and young adults, diffuse pediatric type high-grade glioma H3 and IDH wild type that occur in younger children, and the infant type hemispheric glioma. I'll begin with the midline tumors, that is H3K27 altered. And the first tumor type in this group is the diffuse midline glioma H3K27M mutant, that all of us are very familiar with because it was introduced in the 2016 classification. These are diffusely infiltrating gliomas involving midline structures such as the thalamus, the brainstem, and the spinal cord, and harbor the H3K27M mutation, which luckily for us can be detected by IHC because this serves as a surrogate for the mutational status. And since H3K27M brings about a global loss of the H3K27 trimethylated protein, we can see loss of H3K27Me3 within the tumor cells. Only the endothelial cells are positive, which serve as the internal control. And mind you, these tumors histologically can be grade 2, grade 3, or grade 4. But if any of this harbors the K27M mutation, then it will correspond to CNS WHO grade 4. The next is the diffuse midline glioma, H3 wild type with EZHIP overexpression. So basically, H3K27M mutations that occur through canonical 3.1 or 3.3 histone variants can bring about the loss of H3K27Me3. And it is an inhibitory interaction between H3K27M and another molecule known as EZH2, or the enhancer of Zeast homolog 2, which is the methyltransferase catalytic subunit of the polycomb repressive complex 2, or the PRC2, that dominantly drives the negative effect. However, even when H3 is wild type, overexpression of an inhibitory protein known as EZHIP can also inhibit PRC2. So basically, H3K27M and EZHIP are oncoproteins. They're competitive inhibitors of the PRC2 and both bring about loss of H3K27Me3, thereby driving oncogenesis. And diffuse midline gliomas, which do not harbor H3K27M mutation but show EZHIP overexpression, was initially described by the French groups in this early study by Castel and colleagues. They showed that these tumors, they clustered distinctly on DNA methylation profiling when compared to the other pediatric type tumors, and subsequently their IHC pattern was also described. This is our own small data of 2 years of pediatric DMGs. We had about 22 cases, and you can see that the large majority are K27M positive. So that is the most common of these diffuse midline gliomas. Only 2 were negative for H3K27M, out of which 1 showed loss of Me3. And this was the tumor that showed EZHIP overexpression. So this is our tumor, which histologically showed features of glioblastoma. And by IHC, it was negative for H3K27M, but showed loss of H3K27Me3 and overexpression of EZHIP. And therefore, this is diffuse midline glioma, H3 wild type with EZHIP overexpression corresponding to CNS WHO grade 4. The third is the diffuse midline glioma, EGFR mutant. Now, these are very rare tumors. They occur in younger children. They're bithalamic gliomas, and a series of about 13 cases have been described by Ari Perry's group. These tumors, they harbor EGFR mutations. These are small in-frame insertions within the exon 20 or the missense mutations within exon 7 of the EGFR gene, but they lack the EGFR amplification that we see in the older adults. Histologically, they're high grade. They're either grade 3 or grade 4 astrocytic gliomas. On IHC, they're negative for H3K27M, but they show loss of H3K27Me3. So all these 3 tumor types, that is the diffuse midline glioma H3K27M mutant, the EZHIP overexpressed, and the EGFR mutant, all of them bring about loss of H3K27Me3, and therefore they're designated as H3K27 altered tumors, and all of them correspond to CNS WHO grade 4 and are very aggressive neoplasms. If you look at the hemispheric tumors, the first tumor type in this group is diffuse hemispheric glioma H3G34 mutant. These tumors are exclusive to cerebral hemispheres. They don't occur in the midline, and usually seen in the adolescent and the young adults, age ranging from 11 to 30 years. Histologically, they're high grade. They're either grade 3 or grade 4 tumors. And they have this diffuse gliomatosis like spreading pattern with secondary structures. And in about 1/4 of the cases, the tumor cells are very undifferentiated. They have this primitive neuronal appearance. They have a very characteristic IHC pattern. They show loss of ATRX expression and a diffuse P53 immunoreactivity, features that we see in IDH mutant astrocytomas. However, unlike IDH mutant astrocytomas, they're negative for OLIG2. And the diagnosis can be established by the DNA sequencing for the histone H3, or luckily for us, IHC surrogates are available, that is monoclonal antibody against G34R and V. These two are mutually exclusive, and we can demonstrate this for diagnostic purposes. And since these tumors show MGMT promoter methylation more than 65%, they're usually associated with an intermediate prognosis, regardless of them being a CNS grade 4 tumor. The second tumor type is diffuse pediatric type high-grade glioma H3 and IDH wild type. This is a completely molecularly defined tumor type. One can't really identify this by histology similar or by simple immunohistochemistry. You require molecular methods. There are 3 subtypes in this group. That is the RTK1, which shows PDGFR amplification in about 1/3 of the cases, RTK2 that shows EGFR amplification or third promoter mutation in a large number of the tumors, and the MICN group that shows MICN amplification in about 50% of the cases. And the third is the infant type hemispheric glioma. Now, these are also very rare neoplasms. They are receptor tyrosine kinase driven tumors. And they show molecular alterations involving 4 key genes, that is ALK, the NTRK, ROS1, and the MET. These are usually fusions, and they have several fusion partners, as I have depicted here. Among these, ALK alterations are the most common, and these are associated with the best prognosis amongst this group of infant type hemispheric glioma. ALK alterations can be identified by the FISH technique, but luckily for us, we can also identify by immunohistochemistry. For example, this is one of our cases, a 6-month-old infant with a diffuse cerebral hemispheric glioma, which histologically showed features of glioblastoma, and it showed diffuse ALK positivity. The other IHC markers that are useful in this group of tumors are the ROS as well as the c-MET. The importance of identifying this infant type hemispheric glioma is that there are targeted therapies that are now available that can target these individual genes like the ALK, the ROS, and the NTRK, and all of these are under the clinical trials. So this table shows you the diagnostic modalities that we can use for pediatric type diffuse high-grade gliomas, of course, other than the methylation studies. For diffuse midline glioma, H3K27 altered, IHC markers include H3K27M, ME3, and EZHIP. Molecular markers include the DNA sequencing for the histone H3 variants, EGFR, and EZHIP. For diffuse hemispheric glioma, H3G34 mutant, IHC markers include H3G34R or V. We can use P53ATRX along with this. And the molecular markers include DNA sequencing for these histone H3 variants. For diffuse pediatric type high-grade glioma, IDH and H3 wild type, there is no specific IHC marker. However, all of them show retained H3K27ME3, unlike the midline tumors. And by DNA sequencing, we should show that they are IDH and H3 wild type, and FISH can be used to demonstrate PDGFR, MICN, and EGFR amplification, but that is only in a subset of the tumors, but not all the tumors. And infant type hemispheric gliomas can, the IHC markers that we can use for this are ALK, ROS, and c-MET. And of course, there are the other molecular methods that we can use for diagnosis. So this is a simple tiered approach that we can use for pediatric type diffuse high-grade glioma in a resource limited setting. If the tumor is in the midline, we start with IHC, and if the tumor is positive for H3K27M and shows loss of ME3, diagnosis becomes very simple. It is diffuse midline glioma, H3K27M mutant. P53ATRX can be kept optional, particularly in the thalamic tumors, because these are cooperative mutations in those tumors. Now, if it is negative for H3K27M, but shows loss of H3K27ME3, then IHC for EZHIP will be required. And if that is positive, then it is diffuse midline glioma, H3 wild type with EZHIP overexpression. But if it is negative, we can give an NOS diagnosis. And DNA sequencing can be kept optional only for bithalamic tumors for demonstrating EGFR mutations, because if that is there, then it becomes a diffuse midline glioma EGFR mutant. But we can use NOS diagnosis for all these tumor types that cannot be identified on a routine basis. Now, for the hemispheric tumors, we start with IHC once again. If it is negative for OLIG2, ATRX shows loss and P53 is positive, then H3G34 RNV IHC will be required, as I already mentioned earlier. And if it is positive, then it is diffuse hemispheric glioma, H3G34 mutant. But if it is negative, we have to show that it is IDH wild type by IHC and sequencing. And then it will fall into these groups, that is the pediatric type diffuse high-grade glioma, IDH H3 wild type, or the infant type hemispheric glioma. Now, we can give an NOS diagnosis, although there are some IHC markers that are available for this infant type hemispheric glioma that I mentioned, because all other molecular testing can be kept optional, because sometimes we will also require NGS-based platform for identifying these molecular alterations. I do not want to end without mentioning the pediatric type high-grade glioma that arise in the setting of CMMRD. CMMRD is constitutional mismatch repair deficiency syndrome and autosomal recessive cancer predisposition syndrome caused by the biallelic germline mutation in one of the 4 mismatch repair genes, that is the MLH1, PMS2, MSH2, and MSH6. And these, as we know, are associated with several systemic neoplasms, and in the brain, most often it is malignant gliomas and CNS embryonal tumors. And when we see a pediatric type high-grade glioma with severe degree of pleomorphism and numerous multinucleated giant cells, as you can see here, it should raise the suspicion of an association with CMMRD. Then IHC for the mismatch repair of proteins or the MSI markers will be very important. As you can see, in this case, we have shown that MSH2 and MSH6 is negative, thereby confirming the diagnosis to glioblastoma occurring in the setting of CMMRD. And it is important to identify this group of tumors because now we know that they have different treatment strategies. So with this, I'd like to end my talk, and thank you very much for giving me this opportunity. Thank you.
She's not here, but I think that was a wonderful presentation, especially the last few slides with what pragmatic approach we can use if we have limited access to molecular diagnostics. So I think we can now move on to the next talk. And
good morning,
introduce the
and
next speaker, I'll request
thank you
Dr.
very
Manmohan.
much to the organizing team of ISNOCON 2021 for having me here. My apologies that I'm not there personally.
At the moment, Secretary of the Neurological Society of India. So, yes, so can we start with this?
Good morning, and thank you very much to the organizing team of ISNOCON 2021 for having me here. My apologies that I'm not there personally due to an emergency which came in at the last minute. Thanks, Aditya, for all your support and help. So I shall be talking on the surgical approach to pediatric brainstem lesions and basically how I would approach such a patient. Now, we all know that the brainstem is compacted and densely packed with nerve fiber tracts and nuclei, and this is the reason why people have not really been happy about wanting to operate on the brainstem. And this has been going on for some time, including till 2009, where this particular editorial in Neurology India came out, where they said that we have to be extremely cautious to recommend excisional surgery as standard of care for these patients. But there has been a change in thought, and this is more due to the technology revolution, both in radiology, in the intraoperative monitoring of the patient, the post-operative care that we can give these patients, the surgical techniques and the surgical equipment that we have that help us deal with these lesions. And not only that, it is also the understanding of the different types of lesions that can occur in the brainstem in children. Now, therefore, now what we can offer the children with microsurgery is the possibility of radical excision in some of these lesions, surgery without permanent new deficits, the possibility of stopping progression of disease, the possibility of improving quality of life, and sometimes, of course, even a life-saving surgical procedure. And this is all possible now in microsurgery. But before we go ahead with microsurgery and surgical approaches, I think we had word about the role of stereotactic biopsy, which is very well spoken by Dr. Rajshekhar and their team from CMC Vellore, where they analyzed the results of stereotactic biopsy in 106 brainstem lesions. And they looked at safety, and they said it is safe and indicated in ruling out an inflammatory pathology of an enhancing brainstem mass. And this speaks a lot about what is happening in the brainstem, and which means that, remember, all enhancing lesions in the brainstem are not gliomas, are not high-grade gliomas. And the other thing is that the stereotactic biopsy is safe, because a lot of has been written about the problems with stereotactic biopsy as well. Not only that you get negativity in results, but also that you can have bleeds, you can have neurological deterioration. But I think stereotactic biopsy has its place in certain, a small group of patients, but I think we must look at whether we can really operate on many of these children. So how do we select these patients is what we need to know. And once we select these patients, how do we approach the lesion? Now, to choose the right patient, we must look at some of the patient characteristics, one of which very important in the brainstem is neurology, because very many of these patients present with a very poor neurology. And an example, this is not a child, but a 30-year-old lady who was pregnant when she was diagnosed, became progressively worse after delivery. She got a shunt and a tracheostomy done elsewhere, and she came to us. She was E1, M1, requiring ventilatory support. This was the lesion extending from the pons right up to the thalamus, and we decided to operate on her and give her a chance because the family also wanted us to do something. And we did a telovelar approach, and we found that the lesion was actually presenting in the floor of the fourth ventricle here. And this allowed us to remove the tumor quite radically. And at the end of surgery, we saw the aqueduct, and we're quite pleased with the extent that we were able to remove. Here, I must say that intraoperative neuromonitoring is perhaps one of the most important adjuncts that we use in the operating room when we do brainstem surgery, and I don't think it should be done without this. A good postoperative scan showing reasonably good extent of tumor, and it was an oligoastrosdendroglioma with lipomatous differentiation, received radiation and temozolomide. She improved in her neurology, and she's being followed up. Another child brought with progressive weakness, drooling of saliva, was taken to another hospital, diagnosed as a brainstem glioma, was then sent directly for radiation without a biopsy. Towards the end of radiotherapy, worsened and became less responsive and drowsy, and unfortunately advised palliative and end-of-life care. So when the child came to us, the child was very sick, and an urgent CT scan showed gross hydrocephalus, for which we did an urgent emergency ventriculoperitoneal shunt. The child improved in sensorium. The MRI was repeated, showed an increase in size of the lesion, and therefore we operated once again through the midline telovelar approach and did as good a resection as possible under neuromonitoring. And we achieved quite a good resection of the lesion, and it turned out to be a low-grade glioma, and the child within a month was as normal as he could be, with very happy parents, and the child is being followed up. We also have to look at the lesion characteristics, whether it is circumscribed, location of the lesion, proximity to the pile surface, and the possible pathology, which would help us determine whether we could choose this patient for surgery. Now, when you look at a lesion like this, most often it is diagnosed as a diffuse intrinsic pontine glioma, and perhaps it could be sent directly for radiation, though now there are more indications now for getting a biopsy of these lesions. But one thing that must remember, that something that looks diffuse in the plain study may not actually be a diffuse glioma, may have a circumscribed lesion, a candidate for surgery on the contrast scan. And this, therefore, is a lesson that must be learned, and we must always look at a contrast MRI before deciding. This particular child came to us with, again, weakness and slurring of speech, difficulty in swallowing. We have been doing DTIs for all these lesions. And when we actually did the DTI for this child, we found that all the tracts were moved back, and actually the corticospinal tract was also relatively intact in this child. The tractography showed only minimal involvement of the anterior part of the corticospinal tract, And therefore, we operated on this child. We looked at the FA values and found that it was just about 25% of the FA value was involved of the corticospinal tracts, and of the transverse pontine and medial lemniscus were not involved at all. And therefore, we operated on this through a retrosigmoid approach. We did a partial excision of the tumor, and the child improved very well in the postoperative period. And in 3 months, the child was normal. The child had a malignant glioma, received radiation chemotherapy, and is being followed up. We published this in 2019 as diffuse tensor imaging and tractography in diffuse intrinsic pontine gliomas, and said that it is a major determinant of resectability. And therefore, we firmly believe that DTI and tractography tell us whether a lesion can be resected or not. And we think that there is a new subtype in DIPG where all the tracts are moved away and not infiltrated and destroyed. Therefore, this is what we have to do DTI in all these brainstem lesions. Now, what about the location of these lesions? Dorsal lesions are definitely easier to operate than ventral lesions. And this was brought out by Professor Mehta in 2009 in this publication, where in the A3 lesions described by them, the ventrally located, they said no for surgery and said that perhaps they should be given direct radiation chemotherapy. But once again, thoughts have changed. We have now surgical techniques where we can access lesions in the ventral midbrain through approaches that are safe. And this is one such example, which was published in 2021, which is a very nice article with anatomical dissections of the approach. Now, what about proximity to the pile surface? It has been recommended that lesions coming to the pile surface are better lesions to operate upon. But now more and more we know that in experienced hands, the outcomes after resection of deeper lesions are comparable with those following resections of lesions which come to the pile surface. And it is important that to do this, we need to integrate imaging techniques with intraoperative neuronavigation techniques. And with the improvement in surgical navigation, surgical instruments and technique, we can really do a good job even with deeper lesions. Now, what about possible pathology and reading pathology by MRI? Dr. Mehta again in his article said that it is possible that large focal intrinsic benign tumor may not be subject to surgery and sent for radiation, while it is not possible radiologically to determine whether a tumor is benign or malignant. And we have had many such surprises where we found that a lesion was not actually a malignant brainstem glioma. So how do you approach these lesions? This is a 1996 paper from Spetzer's group, where it's very simple technique of two-point technique, which shows us how to approach. Of course, there have been many other such articles written, which sometimes very complex, looking at the safe entry zones and looking at where the lesion is. And sometimes it can be mind-boggling, but now more and more, what has happened is that the lesions are being segregated into different types, and the approaches are becoming simpler and simpler, so that you have only a few approaches that you use most of the time. And if you look at even this slide, you have very, very select approaches, and these are approaches which will take you almost everywhere. So you have just you abandoned the more invasive approaches and go for the workhorse approaches, as was said in this paper by Spetzler's group. So you most often use the subtemporal approach or the pterional 1.5 approach, the retrosigmoid, the far lateral, the telovelar, or the supracerebellar infratentorial, and these would cover a majority of all the brainstem lesions that one would want to remove. Then I'm going to stop with this case example of a 3-year-old child with the classical clinical symptoms of a brainstem glioma. And this looks like an intrinsic diffuse glioma, but it's actually grossly exophytic. If you look at the radiology very closely, And we approach this like we would do a foramen magnum lesion. And that's the normal cervicomedullary region. That's the cerebellar tonsil. And once we dissect that and lift the tonsil, you can see the brainstem, the gliomatous part of the tumor of the brainstem, and that's the normal cervicomedullary junction. And that's the lower cranial nerves draped across the lesion. And this is then debulked and progressively removed more and more. And we come to the place where actually this, you see the normal the brainstem, and this is the tumorous area, and then you have to stop there before you do further harm. But the good part is that you can do a good tumor excision of these lesions. And though it was an anaplastic astrocytoma, IDH wild type, the child did very well, though the child survived only for a year and a half after the surgery. So in conclusion, I think the concepts in surgical management of brainstem lesions in children have changed. They have changed because of technology change, and we are able to do a lot for these children now. Advanced neuroimaging, including DTI, determine resectability and approach to these lesions. And it's important to understand that reduction of tumor burden and a proper tissue diagnosis are what we are aiming for. The approach to the brainstem needs to be individualized to each patient. We need to keep the approach simple. Most often, we don't need complex skull-based approaches, and microsurgical principles give good outcomes. We are able to do radical excisions of some of the tumors, reduce a lot of the tumor burden on many of the others, and give these children a good quality of life. Thank you very much for your attention, and thank you once again.
I think it's very nicely presented. Definitely the approaches have changed now, the brainstem glioma, and we have shown that one can operate these tumors very successfully. One has to first identify correctly, as Dr. Sridhar said, and tractography, of course, is one of the very important investigations. So many a times, as in the past it was said that more than 2 centimeter size should not, I think it's no more stands true. You can operate as big as 4 centimeter. The most important is that you have to see the tractography. If tractography, I have seen many patients where walking, and diffuse brainstem glioma, and the tracts are passing through the tumor. So on those cases, I think one should not operate, because then you are likely to develop the deficits. And as far as my opinion goes, the quality of life you should maintain. That's the most important. And the fear in the brainstem is always the quality of life. And approach should be, you should not harm. Where you feel that there is no distinct cleavage, you can leave a margin of the tumor, then harming it. So if there are any questions, no? Okay, and we can invite the next speaker.
In parallel with the innovations in surgical techniques and also radiation techniques, collaborative groups have across the world have tried to see if we can optimize systemic therapy, especially using the molecular insights that we have today. So the last talk of this section is on what is the optimal systemic therapy partner for radiation in pediatric type diffuse high-grade glioma. The search for golden handshake continues. The speaker is Dr. Manas Kalra. He's a senior consultant, Department of Pediatric Hemato-Oncology. He was at Apollo Hospital. That's a misprint. He's currently at Sir Gangaram Hospital.
Good morning, everyone. I thank ISNOCON and ISNO for this opportunity. Good memories from Apollo, ma'am, but it is Gangaram now for the last 4 years. So that's my hospital. That's the parking, multi-level parking of the hospital, and we have the tricolor flashing on it this morning. So a little difficult task to talk about adjuvant treatment for high-grade glioma. It is a bit frustrating, but I think, I'll try to demonstrate the best golden handshake possible in this situation. So we know that high-grade gliomas account for around 11% of CNS tumors in children. Advances in the high-throughput molecular techniques have enhanced our understanding of pediatric high-grade gliomas. And major reclassifications have happened. And the latest one is the CNS5. And you know that, we are still trying to accept each and every new terminology that has been thrown on our way. And hopefully we'll be kind of thorough with that in a year or two with all these terminologies. The therapy beyond complete surgical resection and radiotherapy is not well established, and the outcomes continue to be dismal. So what are the challenges in drug development when we talk about pediatric high-grade gliomas? The blood-brain barrier is the biggest roadblock or the hurdle that we face. Unfavorable pharmacokinetics of many of the drugs, dose-limiting toxicities, long-term adverse events, the short-lived response of many of the drugs that we use, and then most of the patients develop resistance to the drugs that are being used or dependence, and once you stop them, there is a disease recurrence. So these are the big challenges that we face, and we have not had much success with whatever we have done for patients with pediatric high-grade glioma when we talk about, as to what is the best adjuvant therapy for these patients. So I would start with temozolomide, which is like the most important drug that we all use, whether it benefits or not. I think each and every patient gets temozolomide. In adult world, temozolomide was demonstrated to have an almost 16% improved 2-year survival. And this is the classic, the famous Stroop paper, and it is called the Stroop regimen, where we use temozolomide along with the radiation, and then later as an adjuvant for 6 to 12 cycles for most of the patients with glioblastoma. When we talk about pediatrics, unfortunately, this success was not replicated in children with high-grade gliomas. So this is the Children's Oncology Group paper, and when they actually compared it with the CCG 945, the results of adding temozolomide were in fact inferior as compared to the CCG 945 study. Although when this whole aspect of why temozolomide was actually making things worse was looked back upon, then they found that CCG 945, by the lack of advanced knowledge at that point of time of the molecular characteristics, in fact involved many of the low-grade gliomas in their study. And that is why the curves were a little better for the CCG 945. So if you really look at it, with the ACNS 0126, the results were not that bad. That was kind of a retrospective analysis that was done, although the paper did show an inferior survival. The next attempt to improve the outcome was the addition of lomustine or CCNU. So when lomustine was combined with temozolomide for these high-grade glioma patients, it actually demonstrated some improvement. Now, these were still inferior to the 945, but the justification remains good. The same thing that, the CCG 945 had some low-grade gliomas included in that. So it showed that lomustine addition to temozolomide did benefit pediatric high-grade gliomas to some effect. What was the reason? Probably the reason was in the MGMT overexpression. So the dual alkylator therapy actually helped you overcome this MGMT overexpression, which was leading to resistance to temozolomide, and that has benefited these patients. So let me just talk about this MGMT overexpression story. It's not that simple. So if we have MGMT overexpression, the outcome of these patients is usually bad. Now, this is the MGMT overexpression demonstrated by IHCs. You can see in the first and the second graph, wherever there was an MGMT overexpression, the outcome was bad. In the ACNS 0432, when the dual alkylator therapy was used, in the MGMT overexpressed patients specifically, the outcome improved drastically. So that means the dual alkylators helped to kind of overcome this resistance that the MGMT was offering to these patients. So let's go back to temozolomide. We know that temozolomide, after going into the system, induces double-stranded DNA breaks, and that is the main mechanism of action of this drug, and this leads to apoptosis. Now, this MGMT overexpression, what does it do? The temozolomide methylates all the amino acid sequences, especially the guanine, and this MGMT actually removes these methylations. So when this methylation is removed, your drug does not work as well, and the double-stranded DNA breaks don't happen. So MGMT overexpression, poorer outcome, temozolomide resistance. But the story is not that simple. There are two more aspects to it. One is the MGMT promoter methylation mutations and the mismatched DNA repair defects that Dr. Vani also spoke about. So if you have a MGMT promoter methylation, as you can see in the first algorithm shown in the B section, you can see that this promoter methylation leads to decreased MGMT expression. And if DNA repair is not happening, it leads to sensitivity to temozolomide. So that is where the drug works well as compared to the other counterparts. If you have a mismatch repair defect in this person, you actually end up having temozolomide resistance. Now let's look at the second one. If you have a normal promoter area, no methylation mutation, you have high MGMT expression, and this leads to temozolomide resistance. And in some cases, despite no methylation also, there can be some form of low MGMT. We do not know the reason, and this can lead to temozolomide resistance. So the things are not very simple. We need to look at MGMT overexpression, the MGMT promoter mutation, and whether the patient has a mismatch repair defect. So I tried to construct this, tabular column, which kind of tells you that if you have the analysis of all three aspects, you will be able to predict whether temozolomide will work well for your patient or not. The other drug that is used traditionally is bevacizumab. I think in the adult world where there are high-grade glioma, especially in the recurrent setting, bevacizumab is added to these patients and has been found to have some benefit. Now, in the pediatric cohort, I would just mention the Herbie trial, where they kind of randomized patients to temozolomide versus temozolomide plus bevacizumab. And bevacizumab was also administered during the post-radiation period as well. But this particular study failed to demonstrate any advantage of using bevacizumab for patients with pediatric high-grade gliomas. Newer ways of administering bevacizumab have been intra-arterial administration. Mannitol is used to penetrate the blood-brain barrier, and then you add bevacizumab and cetuximab, and some advantages have been seen. And these convection enhanced delivery methods or intra-arterial administrations are being tried in many patients. Now, coming to the WHO 2021 classification and its implication in therapy, Dr. Vani has made my job easy. We know that WHO 5 has got these 4 subsets for pediatric high-grade glioma: the H3K27 altered, the H3G34 mutant, the diffuse pediatric high glioma, which are wild for the IDH and the H3 mutations, and the infant type hemispheric glioma. The term glioblastoma multiforme has been removed from the pediatric classification. Now, when we talk about H3K27 altered patients, these are, with the mutations of histone 3. DIPG patients, almost 80% have these mutations. Thalamic gliomas also have got a high representation of this mutation, and they do have a better response to radiotherapy and survival than the H3 3.3, the 3.1s. But when we compare that to the H3G34 RV mutation, these actually have got a worse outcome when we do the inter-group comparison. Now, in this particular subset, HDAC inhibitors have been tried, but the success has not been much. The drugs used have been panabinostat, vorinostat, and valproic acid. Valproic acid continues to be one of the main drugs for our metronomic chemotherapy protocols, and there are newer water-soluble forms of pinabinostat which have some exciting phase 1 results, but I think it will take a long time before they come to clinic actually. The ONC201, which is much talked about, is a first-in-class imipridone. It's a small molecular inhibitor. It works through, inhibition of these dopamine receptor, the DRD2, and stimulates the clip in the mitochondria. This then goes through a cascade and through the trail receptor leads to the cell death. Now, there were some exciting papers about the ONC201. It works in the H3K27 variant of diffuse midline gliomas. And now there are also pediatric trials which have shown some efficacy. The doses have been established. In US, I think the capsule is 125. Those who are getting from Germany get a 170 mg capsule. The drug is kind of fairly well tolerated, not much of side effects. You need to check the amylase level, you avoid milk products along with that. But again, the efficacy is somewhat, doubtful, and we are in early stages where we can actually recommend this drug for all the patients. We have been involved with 4 patients who are taking ONC201, and I think they are too early in their, story to be actually say that, these drugs help these patients. Most of them are taking temozolomide along with the ONC201. The H3H34RV mutant, that is the second classification in the pediatric high-grade glioma. These, as told earlier, happen in the adolescent and young adult patients. Mainly, these are cerebral hemisphere tumors. They have ATRX and TP53 mutation, and MGMT promoter methylation is seen in most of them, which confers a temozolomide sensitivity. Their outcomes are better than the H3K27, and the PDGFR pathway is the one that is altered in these patients, and we are now looking at usage of drugs for this particular pathway that may help these patients. These are some of the other agents that are used for the H3 mutated, but I would say that they're still in the trial phase, and we do not have definite drugs for these patients that can be used in the clinic on a routine basis. The third category is the IDH wild and the H3 wild. Now, they can be further subclassified into WTA, B, and C. The WTB are the worst ones. They have the EGFR mutation, and you may try erlotinib in these patients along with temozolomide. The WTA1 have got the BRAF mutation, RTK fusion, and that is why the drugs like vemurafenib, selumetinib, and trametinib can be tried in these patients, which are the drugs traditionally used for the low-grade glioma patients. The WTC have the PDGFR, and dasatinib may have a role for these patients. The IDH mutant, which is a rare subset in the pediatric high-grade gliomas, account for 6.25%, and temozolomide can be used for them, and there are drugs now available for the IDH mutant variant. Now, we have been involved in using ivosidenib and inacidinib in leukemia patients based on their NGS reports for AML, but we have not so far used these drugs for pediatric high-grade glioma. PARP inhibitors are the other category that are used for IDH mutation patients, and I think they're all under trial, and we need to watch the space for these particular drugs. The infantile hemispheric glioma, these are the ones that are a bit exciting. I won't go into detail, but the group 1 have got these NTRK-driven tumors and the RAS MAPK pathway in the group 2. And entrectinib and lorlatinib are 2 drugs that have been used. Lorlatinib has been used as an ALK inhibitor. Crizotinib has got a poor penetration, Lorla has got a better penetration, and entrectinib has been used in infantile myofibrosarcomas as well as infantile hemispheric gliomas that have got the NTRK mutation. It is important to look at the cancer predisposition syndromes in these patients, the one with the caffeoli spots and the other one with a retinoblastoma, and then later developing a high-grade glioma. Constitutional mismatch repair defect needs to be identified in these patients. And why is that? Because these patients can develop GI cancers and hematological malignancies, and they have got a very, very high mutation burden in these particular patients, and they can be treated with immune checkpoint inhibitors for their control of the disease. So for the scarcity of time, I'll just skip my next few slides, but I'll just briefly mention the names that, immunotherapy has an upcoming role in pediatric high-grade gliomas. Immune checkpoint inhibitors, we know the drugs, they have been tried. They work mainly where there is high mutation burden. The second one is the cancer vaccine. The issue is that they are against particular HLA haplotypes, so they cannot be generalized and cannot be used for everyone. CAR-T, the issue is that CAR-T just targets one particular, antigen, and you may have so many tumor antigens in high-grade gliomas, and that may be a reason for failure. And the last ones are the IDO pathway inhibitors. These are, again, somehow lead to resistance of drugs and lead to immune incompetence. And there are some drugs which are monoclonal antibodies which are being tried for these particular agents. So these are the newer upcoming therapies that we need to look at. So I would just end by saying that, in pediatric high-grade glioma, as an adjuvant therapy, we have miles to go before we sleep. Understanding the molecular subgroups has facilitated appropriate classification. We have had success for many other cancers with the multi-agent, multimodality, and targeted therapy. I think all this knowledge that we have gained about the molecular, aspects of high-grade glioma, we need to harness that information and kind of try to change the tide against the pediatric high-grade glioma. Thank you.
Thank you, Manas, for a very comprehensive and a crisp presentation. I think we can take questions at the end. So I'd just like to summarize by saying that though there is no golden handshake, but there is such a renewed energy and enthusiasm in this area that you can't help but feel that some breakthrough is definitely around the corner. So on this note of cautious optimism, I hand the mic back to the organizers to get, sorry.
Dr. Manas, now with all these use of new chemotherapeutic agent, what is the extent of life which has been extended? How many weeks? That is the crux.
Mike.
So, sir, it has been, I would say that at the moment, the information has been only in few months to a couple of years. Many of these drugs are under trial. So I would not say that this has really changed the scenario too much. But unless we try, we are not going to get anywhere. So at the moment, DIPG still succumb, within 1 or 2 years, and high-grade gliomas maximum would be 3 to 4 years.
Thank you, respected chairpersons, for your valuable time, and thank you, speakers, for a wonderful session. Now, moving on to the much-awaited panel discussion on pediatric gliomas. A look at the obvious, the subtle, the hidden, and the unspoken. May I now invite the chairpersons for the panel discussion on the stage. Dr. Shikha Haldar, she is Director and Senior Consultant Radiation Oncology at BLK Max Hospital, New Delhi. And we have a slight change here with Dr. K Sridhar as a chairperson. He is Professor, Department of Pathology, TMH, and Joint Secretary of ISNO. Please welcome on the stage. I request the chairpersons to please invite the moderators.
Thank you, organizer, for the extensive coverage of molecular landscape. So the final session will be in this group is the panel discussion. So I invite Dr. Meeta Goel and Dr. Aditya to initiate the panel discussion.
Thank you, chairpersons, and thank you, organizers, for having, over here to discuss this important topic of pediatric gliomas.
To begin with, we would like to invite the speakers of the previous talks, Dr. Manmohan Singh, Dr. Suvendu, Dr. Srinivas Chilukuri, Dr. Manas Kalra, and also I think Dr. Sona Pungaonkar. Dr. Sona, are you there? Yeah. Okay. Panelists. So while the discussion about the appropriate position of the chairs is going on, I would like to reiterate the fact which was already shared by Dr. Ramandeep Arora earlier, that pediatric low-grade gliomas have been identified as one of the 6 index cases for the WHO initiative of Cure for All framework for all cancers. With this, I think we will start with the first case, and I'll request Dr. Aditya to take it.
This is the first case. This patient came as a 14 years boy, came with very short history of seizures, headache, and left side weakness. And the patient was evaluated with the imaging, initially with the MRI. Can I, Dr. Sona, to give inputs regarding this case?
So it's a diffuse hyperintense, diffuse hyperintense lesion in the right insular region. It's showing restricted diffusion with low ADC values, no enhancement. I would think of an aggressive low-grade glioma bordering between 2.5. We used to call it 2.75.
Yes, ma'am. Imaging showed there is a diffuse, not a localized lesion with a diffuse intersection, as I told, looks like a diffuse lesion with a moderate to high-grade element.
So the differential diagnosis are?
The differential diagnosis is a gliomatosis like previously described gliomatosis like pattern, which was removed, the term was removed. But since with the diffuse intersection and non-enhancement and hemispheric lesion, we must consider a differential diagnosis of a diffuse hemispheric glioma type.
So I would like to put that gliomatosis a little lower in the list because there's not much of extension that I can see into multiple lobes. So I would still, it's like a restricted lesion, so not call it.
Actually, in the other images, it is actually extending the opposite hemisphere also, temporal lobe. In other, it is not shown. Yeah. It's extending along the.
A lot of architectural distortion, so it would be lower on the list.
Okay.
So with this, I think we would come to Dr. Singh. Dr. Singh, what is your take on, surgical excision for this patient?
Yeah. Actually, if you look at that on the coronal images, because I don't have the axial images completely, the coronal, there's the whole of the temporal lobe is involved, which is extending through the stem of temporal lobe into the even basal ganglia region and even the insular part. And it is also involving the sylvian fissure, and the vessels are likely to be maybe a little bit of more involved. So keeping this in mind, the surgical excision is possible, and especially for the temporal lobe. So you need to take out this temporal lobe completely because you don't have that axial images completely. So I'm taking this decision purely on the basis of this coronal section.
Entire temporal lobe is involved, sir, in the MRI.
Okay, so can we see the image?
Image is not shown, but it's involved.
Okay, yeah. So this temporal lobectomy, and that's why you will have a significant cytoreduction. And if we'll open up the sylvian fissure and see that the status of the vessels, and if possible, we can go into the insula itself and chase that little tumor if it is very well defined and easily suckable, and will not chase this tumor deep into the striatum.
Okay.
So I'll stop at the temporal and maybe a little bit of insula. That's all.
This is the postoperative MRI. As you told, the entire temporal lobe was removed, with the remaining residual lesion in the basal ganglia regions and insula.
Okay. So I think this is what would have been the standard approach for this kind of a tumor. So I would like to come to the pathologist, both Dr. Suvendu and Dr. Ekari. When you see a sample, when this sample comes to you for processing, then how do you take this forward in terms of how do you conduct your tests? Dr. Suvendu first.
So this is a pediatric patient presented radiologically. This is a high-grade glioma. First off, we look at process the tumor, look at the histology proper. Our first approach should be either it is a diffusely infiltrating glioma or it is a circumscribed glioma. In cases of diffusely infiltrating glioma, obviously there will be secondary structure. It is infiltrating into the adjacent tissue. Then we'll assess the cellularity. Then other high-grade feature like evidence of mitosis, evidence of necrosis, endothelial proliferation. So if we can decide either it is a diffuse or circumscribed, high grade or low grade, then we go for the appropriate immunohistochemical marker depending upon the histopathological features.
So what are the common histological, IHC markers that you would do, considering that if it comes out to be high-grade glioma?
Yeah. So first thing, I wanted to do the immunohistochemistry marker for IDH1 mutation. IDH1 usually is negative in pediatric age group. Then we have to do ATRX, which is also come out to be retained in these cases, and ME1 usually is on the higher side. And depending upon its morphology, if it is coming to be astrocytic, we can, or any specific morphology like say high-grade glioma and it is in temporal lobe, if it has a small cell morphology, we can also go for G34R, the immunohistochemical marker. And if it is positive or negative, based on that, we can go for other molecular analysis.
Can I add what was the age of the patient?
14 years.
So can I add on this, sir? Before we go into the pathology, maybe I just wanted to give a small suggestion to our radiology colleagues. Here we are seeing a small child pediatric.
14 years.
14-year-old. It's kind of young kid here. So they're talking about 2.5, 3 is not the ideal way of it. Is when you're talking about adult diffuse glioma, probably it is right. As Suvendu has illustrated in the morning talk, you can see that in the pediatric type of glioma or in the pediatric age, usually even the adult type of gliomas in the pediatric age group, they present de novo high grade. They don't really present a low grade, transform to high grade. So if the heterogeneity is so much is there, like probably we should say it's a high grade. And what Suvendu has told the markers, in addition to that first marker, probably because of the 14-year-old, probably we should have an OLIC2 ATRX as a first pack. Okay, so just to say that if it is an ATRX loss, probably is suggesting because an hemispheric location, what he has very well instituted about H3G34 mutant tumor. Even if you don't have a molecular facility to identify that, it has got a typical immunophenotype. If you have demonstrated that, it can clearly qualify that as this. If by chance, if you don't have OLIC2 negativity, it is OLIC2 positive and ATR rating, even in that science, we should think that probably we are looking about some kind of IDH wild type and histone wild type of pediatric type of high-grade glioma, keeping that age 14-year-old in the picture. That's what.
So I think the message is very clear that the adult gliomas versus pediatric gliomas, they are very different. Still, we have to start with the basic IHC markers like IDH, ATRX, and OLIC2. And then according to whatever the results are, we have to proceed. In this patient, the final histopathology was reported as H3F3A G34 mutant hemispheric glioma. It was IDH negative, ATRX was lost, P53 negative, Chi labeling was high, and MGMT was methylated. So I'll again come back to Dr. Suvendu. Dr. Suvendu, would you like to add anything else, any other marker that you would have ordered for this patient? Any other tests that you would have done? And can you explain this entity once again to us? It's a very, very new entity for all of us.
This G34R mutant, they are usually a hemispheric tumor. Morphologically, there are no specific morphology, but usually there is a small cell morphology, and usually, obviously, they are high-grade tumor with high mitotic activity, necrosis, and/or endothelial proliferation. And this tumor usually show a higher frequency of MGMT promoter methylation. That's how they had a prognosis slightly better. They are put it under intermediate rate of prognosis.
So that slightly confuses me. Please give me a clarification. So we are talking about histone pathway mutation, which is different from the proneural pathway mutation, but still MGMT methylation is common in these tumors?
Yeah, it has been seen MGMT promoter methylation is common in this particular tumor.
Dr.
Very interesting observations.
Yeah.
You're very on to the point, yes, they share many properties of adult type of IDH mutant gliomas, but they are not typically proneural, null in epigenetic signature pattern. But otherwise, the properties they have a mixture. OLIC2 is a good marker of proneuronal kind of expression, where here it is negative. By the way, the mutational phenotype and the global methylation phenotype, MGMT methylation phenotype, and even if you see the radiological features, the heterogeneity, everything mimics like IDH mutant. And what Suvendu has said, like intermediate grade, that
is better than typical diffuse midline glioma, little bit worse than the adult type of. That's why they use the word intermediate glioma.
No, till 2015, I always thought that these are two divergent pathways, but probably these are not absolutely two divergent pathways. Okay.
Child, I think you said it right. I was going to ask them the same question.
Okay.
How MGMT promoted methylation and ATRX loss. So ATRX loss, sometimes people think, oh, it must be IDH mutant. So this is a lesson that in pediatric, hardly ever you will get IDH, but you still can have ATRX loss. And yet you have a very high level of MGMT. They typically can have small cell / PDET-like of features. And also this diffuse infiltration of gliomatosis. And in this child also, I think Aditya will show he lived for about 1.5 to 2 years. So it was not like GBM.
Don't break that.
Yeah, not GBM, but they have intermediate. So this, my question is the same. It's not IDH driven, it is histone driven, but yet ATRX is lost in promoter methylation. How do you grapple?
ATRX is just a chromatin modulating kind of ATRX along with the DAX protein. It helps in chromatin stabilizer. Okay, so where you have when the role of ATRX loss in IDH mutant type, it has gotten telomere-based cell proliferation, like a lengthening of telomere that gives an immortality to the cell cycle or cells, and they live for longer. That's a tumorigenesis. Here in this case, it is due to the DAX protein associated and ATRX protein associated. It is more of chromatin stabilizing activity as a role rather than telomere kind of a role. So ATRX loss or loss of functional alteration of ATRX gene, it is classically described as IDH mutant tumors. It is in histone G34 mutant and also isolated de novo. So it is not necessarily that it is ATRX mutation is suggestive of an IDH. And nowadays, even ATRX loss or alteration is being seen extracranial tumors as well. So that is one of the kind of an ubiquitous pathway for the telomere based one of the pathway for the immortality of the cells. That's what it's not the one downstream pathway that it has to come through IDH.
Okay. A small comment regarding you said that proneural versus all the other subtypes which had come out in the earlier studies. But now there are studies that when you do tumor heterogeneity, it is not proneural is not always proneural. There can be areas of the tumor which can be mesenchymal, etc. So a sharp division within any tumor possibly cannot happen because of the heterogeneity within the tumor, which is now well reported.
Thank you, ma'am. So Dr. Manas and Dr. Srinivas, treatment approach for this patient. 14 years old, subtotal excision done, high-grade tumor.
So as of now, we are treating them just like any other high-grade gliomas. And unfortunately or fortunately, I think the new mutation subtype prognosis has already been mentioned, but we still don't know. I still think there are some, I've gone through, I mean, after you sent me the slides, I was going through a few literature, and there are some which say actually that the prognosis is even worse than H3K27. So we are still learning, but majority of them actually show that they are of intermediate prognosis, which is slightly better than H3K27. But the radiation volume, doses,
essentially same.
Essentially the same.
Okay. Dr. Manas, are you happy to give only temozolomide, or would he be a candidate for CCNU as well, as you showed in your presentation?
So ma'am, at the moment we are using only temozolomide. Although the paper did show that CCNU is helpful, the availability of CCNU is an issue. It's not a very consistent availability of the drug that makes things difficult. The neutropenia is delayed. The patient needs to be monitored properly. And those challenges come in way of us sometimes. We are treating them with temozolomide.
Okay. So this patient was treated with radiation therapy and temozolomide, and I think we have a follow-up of about 6 months.
This is the initial follow-up. Dr. Sona, any inputs from that? What is the routine follow-up you will do? Any advanced imaging, say, you will follow up? And radiogenomically, anything you have seen regarding this case?
So, we are obviously seeing good response. We would monitor with the advanced techniques with perfusion, now ASL, and I think you all are doing one more technique,
Proton transfer.
Yeah. And At 6 months follow-up, there is a good response. There's not much of necrosis in the area. At least I can't see on the flare imaging.
In this,
And,
yes, ma'am.
What else?
In this slide, the lesion appears in the parent tumor bed. Actually, there is a good response with the reduction in the size. Radiogenomically, anything you can predict this tumor?
In terms of?
H3G34 mutant glioma. Radiogenomically, anything's there?
No, you will have to help me with that. I don't have.
Okay. Based upon this tumor, if any tumor which is a diffusely hemispheric involvement with, without enhancement, and if it is showing diffusion recession, you must predict this tumor because usually non-enhancing tumor.
That was in the pre-op, right?
Pre-op, we can predict. Usually these tumors don't show enhancement, no perfusion, no enhancement. Only diffusion recession will be seen.
Okay. So pathologists, be aware. The radiologists are trying to, poach over and predict based on the imaging. I think
before we end this case, as the chairperson, I want to ask to the moderators and as well the panelists, how different you treated this case after knowing this entity at G34? Maybe 5 years back when you are not knowing it, would you have treated any differently?
I don't think so. I think in terms of treatment, we are just right where we were. Dr. Jalali, unless you want to quickly add something.
We treated the same, except that we went through, it was like an eye opener. We went through quite a detail. We actually presented this case in one of your NCG tumor boards also. And this child, we did the PDGFR, it was actually overexpressed. We did think of giving dasatinib because that paper had just come. I think in Cell, it came in this Cell paper, which we also showed. But Dr. Ramya and I, we discussed at length. We gave bevacizumab. He showed some benefit at the time of progression. We have not seen the progression MRIs. After 1.5 years, he did progress.
Must be a passenger mutation. Probably it's not a driver one.
Could be the passenger. But unfortunately, we couldn't give dasatinib because I was told that it's also not without quite a bit of side effects. He had taken 18 cycles of temozolomide already and some CCNU as well because of promoter methylation. So we couldn't give dasatinib, but I think there are some studies which are trying to explore.
So Ramya is there, I think,
comment.
very short. So dasatinib is fairly well tolerated. There are some side effects, but I think we can manage them and just we need monitoring. So I'm sure Ramya is using a lot of dasatinib for her lukes and CMLs. So I think, yes. So those are the other aspects, whether it will benefit at that point of time, because as compared to the other TKIs, dasatinib has got a better CNS penetration.
I just wanted to add what Dr. Bari's comment on what's the difference to practice. And I think we also have to look beyond the individual patient. If the classic example being with the Wnt pathway where they use 18 gray versus 23.4 gray, it has to be done in a prospective, our Indian context, study trial to be really able to understand what's happening and how does it change the practice. And we are not there yet, but hopefully we'll be there soon.
Okay. Thank you so much. I think with this, we will quickly come to the next phase.
Okay.
You want to add something?
This is the second case. This is a 1 year, 10 months old girl presented with a history of continuous blinking of bilateral eyes past 2 months, and patient was evaluated with the imaging MRI.
Dr. Sonal, you want to add something? Yeah.
So it looks like a surface lesion. Solid areas look aggressive with the restriction, I think cellular. It could be arising from the cortex or the meninges. I don't see any dural tail, so maybe a surface lesion. A PNET with this hemorrhage within the lesion. So that would be first, I would have thought of, or an aggressive meningeal if the dural tail is there. Then.
Actually, the ADC was not low. ADC was not much restrict diffusion, mild restrict diffusion only.
Okay.
So what will be your differential diagnosis for this patient?
So much cystic areas there, and there was hemorrhage and much mild restricted diffusion only.
Okay, so, but it doesn't look extraction to me.
Okay. Actually, this lesion showed mild restricted diffusion only and showed cystic areas and entrance enhancement and hemorrhagic areas.
So PX, like a cystic, solid cystic lesion, like an aggressive PXA would be the first one.
Okay.
1 year, 10 months.
1 year.
1 year, 10
Very
months.
engaged, ma'am. Since it is
Hemispheric ependymoma.
supratentorally, we can think as ependymoma since cystic areas are there. Another
It
differential.
wasn't really reaching up to the, so cortical
okay.
ependymoma, the lesion is too large for
Okay.
the presentation.
Okay.
Astroblastoma is, yeah.
No significant edema, so astroplasma, one of the differential we can consider. These are the three differential diagnoses we thought of.
Dr. Singh, happy to operate this patient?
Exactly, this is a surgical case. There's no confusion about that, and it looks very, I would say that localized tumor, it's not infiltrating. And I believe that there will be a surgical plane. And we should have, I would say that preoperative evaluation on the functional MR and DTI and intraoperative monitoring is needed. And it should be excisable.
Okay. So this patient did undergo surgery and the final histopathology came out as intracranial myxoid mesenchymal tumor ESWR1 CRB fusion positive. I have heard of this term for the first time. This is not my case. I am nervous. I am nervous to read this out. I'm speaking on behalf of a lot of people who are sitting in the audience. We work in small centers. We do not have dedicated neuropathologists. We do not have a lot of sequencing facilities. I think we will be completely lost if some of these cases come to us. Dr. Suvendu, Dr. Jalali, Dr. Ipari, you have to help us.
It was a complete shock to us also. It's not only for small centers.
The message what I'm trying.
No, it was
forget
called,
about the name of the tumor
Sridhar,
first.
it was called, let me tell the history. It was called ATRT.
So you go back to the radiology, sir. There was some cleft-like space was seen around.
Okay.
So we could not decide whether it's an interaxial or extraaxial. First step is that. We could not decide on the radiology. Maybe we could have taken the input from the surgery.
It was brilliantly excised, by the way. There was complete excision except a small tiny nodule in the medial. It was called ATRT in one of the premier centers, came to us for proton therapy actually. So we couldn't, but the INI was retained, wasn't it? Something was there in this case.
Yes, sir.
And that was very odd. And we did an NGS. Basically, it had what Manas told us. So we did the NGS for the lack of any other thing to do, what to do. And then it came out to be this ESWR, there are CRAM and CRAB fusions. And then Dr. Sushma told us that this is a tumor, 26 cases only have been reported in the literature.
So don't worry, guys.
So we
it's
are
not an
all in
easy
the
tumor.
same
It's
boat.
not an easy tumor.
Maybe if I can
Recently included
maybe
21.
Chitra ma'am can elaborate further. What I'm trying to tell you, sir, these are all entities that were used to be clubbed as a non-descript terminology, meningeal sarcoma NOS. Okay. Now, just like the way brain tumors, based on the molecular alteration, you're delineating the entities. Even in the soft tissue tumors, many of these fibroblastic myofibrillary differentiation with the alteration, they're getting the name of the tumor with the alteration. So this is a descriptive terminology as a myxoid mesenchymal tumor with the what is the molecular alteration. The Krebs fusion with the EWSR. This also comes under family. If you have an EWSR and probe, break apart probe, you can demonstrate the loss in the rearrangement of EWSR1 gene. And this, I'm 100% like, histologically, you would have got the diagnosis of some mesenchymal tumor, NOS, something like that. Probably we could give the name to it. After you get the name, it is like that. Vinita, to confuse us, you have put ESWR. Is it ESWR? EWSR?
Oh, I can be absolutely wrong.
EWS. So this is the fusion between ESW. Yes.
Got it. My apologies. So you can see my ignorance. So Srinivas, going further, how is the prognosis? How do you treat this? Just observe. I'll just show you the post-op MRI also. Complete excision.
Again, as Dr. Sridhar mentioned, I would have treated ATRT. Maybe chemo would have been different slightly, but finally radiation. And I would have loved to treat a sarcoma with a craniospinal radiation, but it's very young child. Obviously, that is not an option. So focal RT only. So I'm sure Dr. Jalali would have treated with a focal radiation therapy.
Not observation?
Not really, because it's a high-grade sarcoma.
It had a very high-grade. Ki67 was 50 to 60%.
Yeah, it's a high-grade
brisk
sarcoma.
mitosis. In fact, we discussed it. So we are going to give adjuvant chemo. She has finished the proton therapy. There is absolutely, there's no residual disease now. The question was, so you are right. There is a spectrum of relatively low grade where you can observe. And apparently the CREB one is better than CRAM one, which we also learned. I think the message is not that what is this fancy tumor. The message is in the last year or two, we have realized that very young children with these type of tumors is a case for fusion NGS. And many a times you get lots of targetable. So
one more entity which we have seen is BCOR.
NTRK fusion,
BCOR.
BCOR, ROS pathway, RET pathway. So these can help
I
you.
just wanted to comment, say that sarcoma is also a fusion disease, like what you are seeing in pediatric low-grade glioma. Sarcoma is also fusion. As you rightly said, you can subject to the RNA sequencing or different fusion plan. But in 1 year, 10 months babies, taking the histological features of the MIP proliferation index, taking as a craniospinal, I don't know. Because if you say infantile fibrosarcoma is one of the highest mitotically active tumors, they have a very good prognosis. So when you have this thing kind, we really don't know whether we should give a child of not having an undifferentiated or primitive embryonal tumor, craniospinal suggestion, vis-a-vis focal artery, probably nobody
Dr.
knows.
Sridhar, nobody knows,
Yeah,
but it's a
that's right, nobody
high-grade
knows.
sarcoma. That is the rationale. But of course, not in a 1 year or 10 months.
So-
Definitely not.
So
That's why I
high-grade
said.
sarcoma in an infantile age group, vis-a-vis high-grade sarcoma in an older pediatric, vis-a-vis an adult population, altogether different. I
That's
think the
why focal
pediatric,
artery. That is why focal artery.
So I think my message here is that these kind of tumors need probably some kind of central pathology review by expert pathologists, NGS, and probably the treatment is based on the oncological sense rather than correct evidence. So
But you got the central diagnosis, no?
Correct,
So
correct.
they still we don't. So
Correct,
it's
correct.
not like central path review is important. Probably we need to wait for the medical evidence to get accumulated. What exactly, what the doctor was suggesting, like we need to have in some trial setting for radiate tumors to have that way. Otherwise,
So this patient was treated with
I have
radiation.
one more question.
Yes.
Do we need to do like, we are comparing with the PLEDs, like do we need to do any spinal protocol, CSF, MRI?
Spine MRI was done. Spine MRI is normal screening.
I have one question.
Yes, ma'am.
Manas, will you treat this as a mesenchymal tumor or because of its location, the basic tenet by which they would respond is by what they are?
So I was told by Vinita कि इसको treat नहीं करना है. No medicine has to be given.
No.
But I personally thought, oh my God, what is this tumor? I have not heard the name, but the way it looked like, and it is like a sarcoma, and it's a young baby, and you've got a good excision, and the MIP index is so high, I would have given IFOS doxorubicin to this child.
Manas has actually offered me a cup of tea for not asking him, this case.
All the others that you have in the lot.
We are running short of time. We will quickly run through some of the cases.
so-
These are just to make all of us aware about some of these new entities.
This is the third case. This is an adolescent female with history of recurrent intractable seizures past 3 years. The patient was 8 years. Patient was evaluated with imaging CT followed by MRA. This CT imaging showed there is a left temporal lobe, a lesion with a peripheral rim of calcification, and this the T2 images and FLAIR images contrast showed cystic lesion with the peripheral enhancing nodule.
I think we
Differentials.
will quickly move ahead. I'm sorry.
First, ganglioma.
Okay.
yes.
Okay.
These are the differentials we thought. Is a classical feature of ganglioma, and other PXA also cystic mural nodule. And another thing is recently described entity. This also can be included plenty.
So you'll be happy to operate this patient. This comes into the, Dr. Singh, you'll be happy.
So definitely it can be, because this is one of the, I would say, the non-eloquent part of the brain. So you can have a gross-total excision, even if it's a malignant one. So with the margins, the safe margin. So
Yes.
surgery is possible and it should be excised aggressively.
Dr. Suvendu, you did talk about it. Could you elaborate more on this?
I really first want to see the slide as a pathologist because all our thought comes from seeing the slide. So saying any approach by this, because I want to see is this tumor is a circumscribed tumor or it is a diffusely infiltrating tumor. Then if it is circumscribed, whether it is low grade or high grade. So depending upon that, depending upon the morphology, I can decide the further marker. Like if it is PXA, my marker, panel of marker will be different. If it is like oligodendroglial like morphology, my panel of marker will be different. Obviously, If it goes in the line of range, like if you have calcification, if you have oligo-like area, I'll go for CD34. That I can do on immunohistochemistry. And obviously, I want to exclude the adult part of gliomas. That is can be easily done by ISC by doing ITH and other ATRX P53. And obviously, I'll see the polyphytic activity on B1.
So this patient did undergo surgery and was kept on observation after that. I think in
surgery alone is curative.
Surgery alone is curative for this
case.
low-grade kind of a tumor. And majority of these patients, as Dr. Suvendu also mentioned, they look like morphologically, they look a lot like oligodendroglioma, but they have a different molecular connotation added to them. And they have typical imaging features based on which generally they can be identified and they can be very well distinguished from oligodendroglioma also.
Usually they'll be more cystic, and usually most of the tumors will have calcification, more common in the temporal lobes. But same imaging features like ganglioma also may have similar features.
Correct. So do we have more time? Okay.
Just
so
a small comment.
Yes, sure.
So what you showed, the spectrum of lesions are all under the description of long-term epilepsy associated lesions.
Correct.
In those kind of lesions, the surgeon is the only thing. Cure of
Surgeon is the
epilepsy,
only-
nothing to do anything more.
Surgeon and the pathologist.
Pathologist will not do anything. Even if you describe, even if you tell something and all, you will decide to observe. Because when you gave the description of intracranial myxoid tumor, EWS-R1 fusion, you still wanted to observe. So pathologist just give the name, but ultimately the call is taken by you people.
So I think it's a multimodality approach which is required. So thank you, panelists, thank you, chairpersons, and thank you, organizers, for giving us this opportunity.
Thank you. Thank you.
And thank you for also correcting the mismatch repair defect,
So the take-home message is we have a lot of knowledge and we don't know what to do about it.
Thank you everyone for a very interesting panel discussion. Moving on to the final wrap up of this first session on pediatric gliomas, we have final take home pearls, which will be presented by Dr. Ranjit Murthy. And he's professor and head of Department of Neurological Sciences at Christian Medical College, Vellore. And Dr. Manas Kalra, Senior Consultant, Department of Pediatric Hemato-Oncology, Apollo Sri Gangaram Hospital, New Delhi. Please welcome.
Good morning to all of you. At the outset, I would like to thank Dr. Aditya Gupta and Dr. Bansal and all the organizers of this meeting for having invited me and given me the opportunity to share our views on pediatric gliomas. So I will be validating a lot of the things that speakers before me so nicely illustrated and described in this brief talk, with some emphasis on surgical management. So the goal of surgery in pediatric gliomas, as Dr. Singh very nicely mentioned, was maximal safe resection wherever possible, with preservation of neurological function. So this may be possible very easily in cerebellar hemispheric tumors and lobar gliomas. However, when it comes to the deep-seated tumors in the thalamus or the brainstem, we really need a lot of adjuncts, like there was mentioned, like the intraoperative ultrasound, navigation, a DTI-based planning of the resection based on to look at the location of the long fiber tracts, functional MRI, and of course, intraoperative neurophysiological monitoring. One thing we need to consider while operating and planning surgery for these children is blood loss, particularly in malignant tumors and high-grade gliomas. For example, even the ones that was shown, the example was shown the last case, that was the circumscribed right posterior frontal glioma, we could have significant amount of blood loss from that. And hence we need to prepare for that and plan treatment, plan our surgical strategies based on that. So I would like to illustrate a case from our experience. This is a patient, a 13-year-old boy who presented with 13-year-old boy who presented with left hemiparesis, and he had a large right thalamic with a cystic thalamic glioma. So the mouse is not working. So you can use the point. This is a cystic glioma, and we planned a transtemporal excision of the tumor. We use here dynamic white matter stimulation, wherein a probe is put and current is given through this probe while dissecting the tumor of the adjacent white matter. And in the depth, we found that when we were trying to dissect a small area of the cyst wall, we got responses from the right upper limb at 10 milliamps current strength, which means that the corticospinal tract is located about 10 millimeters away from this. Hence, we decided to leave behind a small residue of cyst wall, which is seen here at the 1-year follow-up MRI. It's a small area of enhancement, and we are continuously following up this patient. The biopsy came as a pilocytic astrocytoma, and he did not receive any adjuvant therapy at this point in time, but it's important to follow up this case regularly. This is another child, a 7-year-old girl who presented to us with seizures, 6 months duration. And this is a preoperative MRI showing the yellow line depicting the central sulcus and the precentral gyrus well circumscribed lesion, which we excised using the help of central sulcus mapping. So what we did is we recorded the SSCPs, so the somatosensory evoked potentials, from the cortex, both behind and in front of the lesion. And there was a phase reversal seen here. You can see one wave is down and the other wave is up. This phase reversal indicates that we are at across the central sulcus, and this lesion is actually situated in the motor cortex electrophysiologically. However, since the plane of the lesion was good, we were able to excise it radically as seen in this MRI. The biopsy came as a pleomorphic xanthoastrocytoma. And since this is an epileptogenic lesion, we also managed to achieve seizure cure at a follow-up of 3 years that we have this patient. So what are the functions of intraoperative monitoring during glioma excision? They help in mapping of the dorsal columns, particularly intramedullary tumor surgery, mapping of the brainstem nuclei, and in central sulcus mapping. And they also improve the safety of surgery by warning the surgeon of a potentially reversible neurological dysfunction when the motor evoked potentials are monitored. And also they improve the postoperative functional outcome by preventing neurological deficits. They also improve the extent of resection because the surgeon, as a surgeon, I'm reassured repeatedly that the surgery is safe and the MEPs are preserved, or when I don't get any responses on dynamic white matter stimulation, I can go ahead with some more excision. So in pediatric gliomas, the extent of resection is important, as I mentioned. So in low-grade gliomas, it has been shown that when there is more than 95% tumor excision, the GTR, the progression-free survival is almost 100% can be achieved at 10 years, while with STR, we achieve about 67 to 80% 10-year survival, 10-year survival. And in high-grade gliomas also, when there is a gross total excision, the progression-free survival at 5 years doubles almost from 17% to 35%. And in circumscribed gliomas like pilocytic astrocytoma, the total excision can be curative in several cases. Total resection helps in seizure control, as was demonstrated in case. And there is a recent report which says that even in thalamic gliomas, gross total excision may be able to obviate the influence of the H3K27 mutational status. But this is in a small group of patients, and this needs to be validated by several other studies. Now, coming to a few examples of brainstem tumors, this is an example of a partly focal and partly exophytic tumor in the pons, where this 13-year-old girl presented with diplopia and difficulty in walking. We did a partial excision of the tumor with MEP monitoring and the brainstem nuclear mapping. And since we were not able to find the good plane within the brainstem, although an MRI looks like got a very well-defined plane, we decided to stop with partial excision. And we gave 3D CRT for the post-op residue with the child is undergoing now. And she had no new deficits. So in brainstem lesions, this is important. Preserving the existing neurological function of the patient is as important as achieving a maximal safe resection. This is another example where of a cervicomedullary junction glioma, which is again surgical case where it's been excised radically with MEP monitoring with no residue seen and no adjuvant therapy given, as a biopsy was of a pilocytic astrocytoma. However, this is a patient which would be debatable, where this is a large tumor which is in expanding the pons, and you can see apart from the enhancing area, there are several, the entire pons is involved tumor, and we consider a diagnosis here of a diffuse glioma. The patient had presented to us with hydrocephalus, so he was shunted and direct RT was administered. And at 4 months post-RT, there is significant reduction in the tumor size. The patient had come to us with extrusion of the shunt, so the shunt was actually removed. We were able to make him shunt-free treatment. So the approach to brainstem gliomas should be maximal safe resection with or without adjuvant RT in patients with cervicomedullary junction glioma and dorsal exophytic glioma and focal gliomas, leaving behind residue along the fourth ventricular flow to avoid new deficits, and direct RT in the diffuse intrinsic pontine glioma. And there is still a debate going on whether to biopsy these tumors or not. However, we as well as several others have shown that mortality in children with a low grade or high grade morphology in this diffuse intrinsic pontine glioma location is similar. This is another child with a progressive right hemiparesis who was operated in 2008 for a thalamopeduncular cystic pilocytic astrocytoma and was then followed up. In 2013, she had a symptomatic recurrence and was reoperated. There was a small residue which has been followed up for 4 years. And now in 2018, we found that the lesion started to grow and she was advised stereotactic radiation therapy, but she defaulted. So even in these circumscribed gliomas, pilocytic astrocytoma morphology requires very long and close follow-up because it can recur. So what is the role of radiation therapy in pediatric gliomas? They do definitely improve the progression-free survival and the overall survival. And with these newer techniques, conformal techniques and stereotactic and proton beam techniques, both as the Indian groups have shown as well as several others have grown, RT has become much safer, and we should not shy away from giving RT for these children when necessary. So in pilocytic astrocytoma, the indication for RT would be residual disease after resection, and tumors which are non-resectable or very highly eloquent region or deep-seated, which are not resectable, or when there's a progression in small residue that's being followed up regularly. For WHO grade 2 to grade 4 tumors, early RT may be necessary for residual disease after resection, and again in deep-seated location tumors and non-resectable tumors. So the prognosis of gliomas over the last 30 years has changed from just a phenotypic classification to now moving on to genotype, and with several new additions being made in the WHO 2021 classification. IDH, in addition to IDH, the TERT promoter and CDKN2A deletions being added on. And why are we adding these molecular signatures? It's with the hope that we would be able to derive targeted therapies, as Dr. Manas said, in trying to improve the outcomes of these patients, which hopefully we shall see in the future ISNO meetings. So I would like to summarize by saying that management of pediatric gliomas is essentially has to be done by a multidisciplinary team consisting of a neurosurgeon, a radiologist, a neuropathologist, a molecular biologist probably in future, a radiation oncologist and medical oncologist. And the goal of treatment should be extent of maximal safe resection and preservation of neurological function with appropriate use of adjuvant RT and targeted therapies with limited systemic toxicity. Thank you.
I think if it's okay, we can close this session because anybody has any questions or yes, ma'am.
So how long adjuvant TMZ in high-grade pediatric glioma you will give? Adjuvant TMZ, how many months?
Anybody would like to answer that question? So it is 6 to 12 cycles, ma'am. Generally, for pediatric high-grade gliomas, we give it for 12 cycles for all our patients.
And with the use of lomustine, what sir has said, because 5 days back we have done pediatric high-grade gliomas. So we have discussed in tumor board. So finally we have started with TMZ. So lomustine, what?
It has additional benefits. So we need to understand the toxicity of lomustine. It is not like the other conventional chemotherapy agents. The neutropenia sets in quite late. The clinician should be aware of that fact because it can be somewhere around 30 days, 40 days by the time the neutropenia is coming in with this drug. So if the drug is available, I think it can be added to temozolomide.
Okay.
One question I have for Dr. Chitra. Dr. Chitra is there?
Chitra ma'am was just here. I think
okay, Sridhar, any pathologist?
Dr. Vaishali is there.
What about the high-grade glioma with pyloid features that we have not discussed? And is it the same as what we call anaplastic pylostick, or they are two different entities? How should we approach them?
They are different entities. High-grade gliomas with pyloid features. The diagnosis has been established by methylation profiling only. At this juncture, methylation profiling is the only criteria for accurate diagnosis. But there are some markers like these tumors show ATRX loss, 1p, 19q co-deletion can be seen, and the key point is that they have activation of the MAP kinase pathway. So they can be, they are targetable.
How is it different than anaplastic pylostick?
Anaplastic pylocytic will have typically BRAF-KIA fusion, and secondly, they show high-grade features like you see mitosis, you can see necrotic areas. MAP kinase pathway, of course, is activated in that, but they will not show loss of ATRX and this 1p 19q. And these tumors, they typically, like whatever the cases are available, they are typically seen in cerebellum, and they are seen in middle age. Like we have seen one case in a 60-year-old male.
We have seen in late 20s and early 30s. That will be very young age.
So you have seen.
Yeah, in 20, they are typically posterior fossa. You are right. Yeah.
So just one last question, and then we'll close the session.
Just I wanted to know the use of adding bevacizumab along with temozolomide for the gliomas that you mentioned, sir, in your talk.
So as I just briefly mentioned that, I think for adult recurrent high-grade gliomas, bevacizumab has been recommended. I was just going through the EANO guidelines, which say that, bevacizumab is one of the agents that can be used. In low-grade gliomas, wherever you have like a rapid visual deterioration, bevacizumab can be used. In pediatric high-grade gliomas, again, it has not been found to be much useful as per the big Herbie trial, which showed that addition of bevacizumab does not help. But again, in desperate situations, this can be explained to the families, and there will be anecdotal cases that will be benefited from the, it is a desperate situation, and these drugs may be used. But as a general recommendation, I don't think it adds much to the outcome of the patients.